Hello, everyone. We are so thrilled to welcome you to the inaugural Pepperdine Oncology Symposium. Yay! My name's Deanna Smith, and I need this to be higher. There we go. Deanna Smith, and I am the chair of the Board of Regents here at Pepperdine University. I'm an alum, and does it feel great to be here. I'm also the CEO of Sarah Cannon Research Institute. We conduct oncology clinical trials, and our mission is to advance therapies for patients. And when I think about Pepperdine's mission, and I think about healthcare, I'm inspired at a completely different level. And President Gash, I want to thank you and the leadership team for your commitment to science, for your commitment to healthcare, and for all the investments that you've made to date and will continue to make, right? Yes? All right. So this symposium is the convergence of the two for me. Imagine how I feel knowing that my driver is my faith. My heart is my friends and family, but my passion is cancer patients and Pepperdine University. And so having this in one place, I mean, Madison, it's pretty amazing, right? I'm so grateful to Madison. She's going to welcome you in just a moment. But I wanted two things that I think are important. One is that there's a QR code both in your brochure and on the slide. And we want to gather your questions, particularly from our amazing students, so that we can answer those in a later Q&A that I will facilitate. So please think about that. I also want to thank our sponsors. Phil Butel, who is the CEO of Los Robles, is here with us. Los Robles is a sponsor, but I want to brag on Phil for just a moment and for the College of Health Sciences students. HCA Healthcare, which is the owner of Los Robles here in our local area in Westlake, made an incredibly generous donation of $4.8 million to start the nursing school at the College of Health Science. And I want to say that Phil Butel helped to drive that to completion. And Phil, we are so grateful for your advocacy, for everything that you do for Pepperdine and the partnership that we have together. Provost Brewster. You know, it's a weird thing when you're the chair of the board and you say to the provost, we'd like to have this oncology symposium, and he's like, wow, hold on, yes, let's do it. And so I'm so grateful, Provost Brewster, for your advocacy, for your sponsorship. Really, really grateful. You're a scientist yourself, so I was hoping it wouldn't be too hard of a arm twist for you. Dr. Lucas, who is the Dean of our Natural Sciences Division, without him, none of this happens. Madison, you might not happen without Dr. Lucas. He is so amazing and cares so deeply for our students and has been at Pepperdine for a long time. And then my company, Sarah Cannon Research Institute, we are sponsoring as well because if I want to have it, right, I got to put my money where my mouth is. So Sarah Cannon is sponsoring as well, and Dr. McKenzie from Sarah Cannon will be on our panel as well. I want to tell you guys, today is special. Anytime there's a first, it's special in this context. But the caliber of guests that we are going to have on stage today is unbelievable. I'm going to introduce Dr. Gralow in a moment effusively. She's so amazing. But also, maybe the most esteemed person who will be with us is a patient, Terry. Because everything that we do, academic, clinical, and otherwise, is to serve patients. It's our mission at Pepperdine. It's our mission in healthcare. And so perhaps Terry is, well, not perhaps, you are our most esteemed guest. Terry, thank you so much for being with us. One last thing, Madison, and then I'll hand to you, is there is a healthcare symposium on March 12th, the future of healthcare. with a particular focus in AI. And so I would encourage all of you guys to register for that. We're making moves at Pepperdine in healthcare. We are making moves, and we want all of you to be a part of that. Madison, before I hand to you, you are phenomenal. It has been an absolute joy and privilege to work with you in this, because we want this to be student-led. And I am so grateful. Thank you for all the hard work, and I will hand to you.
Thank you. Well, wonderful. Thank you so much, Deanna. So good morning, everybody. As Chair Smith said, my name is Madison Johnson, and I'm a current senior majoring in biology on the pre-medicine track. So like some of you in the audience, I'll be graduating in a little over 2 months. So it really is just such a gift to gather together to discuss such an important topic, cancer. And not only cancer, but what are the discoveries that have redefined treatment over the past decade? And what are the ways that we, not only as a scientific community, but as informed individuals, friends, family members, and supporters, can push for continued breakthroughs, transformations, and healing? So I asked these questions as a student inspired by experiences that have shaped my understanding of the sustained dedication put forward by researchers, physicians, and industry leaders over decades. Their work has led to the treatments we have today and will usher in the breakthroughs we celebrate tomorrow. And this touches on the origin of this inaugural Pepperdine Oncology Symposium. In the summer of 2024, I had the pleasure of interning at the German Cancer Research Institute in Heidelberg, Germany. This was a time of deep inspiration as I contributed to a novel therapy in a community that was intercultural, collaborative, and driven by the ultimate goal of helping the patient. Interning at Sarah Cannon Research Institute was transformational in a different way. At Sarah Cannon, I got to see such discoveries touch patient lives. The opportunity to study drug mechanisms, join tumor boards matching patients to trials, and then walk alongside those same patients in the clinic encompassed a profound full-circle experience that deepened my appreciation for bench research while solidifying my heart for understanding each patient's unique needs. And therein really lies the heart of how today came to be. Through the mentorship of Chair Smith, this question began to take shape. What would it look like to bring this full circle understanding of drug development in oncology to the broader community? Well, we're hoping to do this through a very exciting schedule for the day. We are honored, of course, as we've said, to host Dr. Julie Gralow, Executive Vice President and Chief Medical Officer for the American Society of Clinical Oncology, as our keynote speaker. Dr. Gralow is a leader who has applied her heart for service to help others in multifaceted ways, walking alongside not only her patients in the clinic, but also an international population of women through her nonprofit work. It is also our immense honor to host Terry Palastro, one of Dr. Gralow's patients, who will share her story and ground the day in its true purpose, the lives touched by innovation in cancer care, and, as we'll hear from her, the transformational nature of a physician who is not only there to treat your disease, but who understands the honor of walking alongside you. For our Leaders in Drug Development panel, we are thrilled to hear from Doctors Sarah Hurvitz, Andrew McKenzie, Shayra Shuri, and Lindsay Murphy, experts across clinical care, industry, and research, creating an exciting opportunity to learn about the modern breakthroughs that are shaping oncology from all angles. We'll conclude the day with presentations from current students beginning their research journey, highlighting that a heart for service and innovation begins right here at the undergraduate level. So, with this rich agenda, throughout our keynote and panel discussions, as Deanna mentioned, we invite you to submit your questions using the QR code found on the back of your programs and displayed on the screen during the panel session. You'll be able to submit your own questions and then also upvote those that you're most interested in. We'll then conclude our morning with a dedicated Q&A featuring all of our speakers, giving us an opportunity to explore the topics that you're most interested about. So with that, there really is only one thing left for me to say. We ask that you engage in conversations with other guests, seek to be inspired by the dedication to their vocation our speakers encapsulate, and join us in celebrating the progress and continued progression of great science centered upon patient outcomes. With that, I will hand it back to Chair Smith to introduce our esteemed keynote speaker, Dr. Julie Gralow.
So I want to give you guys a little bit of context about Dr. Gralow. First of all, if you don't have a brochure, you need one. read about these speakers. I want to give her every moment of time, and Madison did a great job of outlining who she is and her position. But I want to tell you two things about her that contextually matter. The American Society of Clinical Oncology, its membership is 45,000 of our closest friends in cancer. We meet in many venues. The annual meeting is in June, and Dr. Gralow is the chief medical officer of this very large organization. The journey to get there is long to be in the position that she is in. She was voted on by her peers, and she is well regarded across the world. And perhaps the most important thing, Dr. Gralow, about you is how deeply you love and how deeply you care for your patients, which will come through when we listen to Terry. She loves, and she's compassionate, and she cares, and that's why she is here at Pepperdine. You guys, she could be anywhere. She speaks all over the world, and she chose to spend her time with us today. So without further ado, Dr. Gralow.
Wow, thank you for that introduction. Thank you for having me. I mean, this is fun. This is what my job is now. It's to encourage all of you to pursue your dreams and also think about going into healthcare, okay? So I know many of you are here because you're thinking about a career in healthcare. I entitled my talk, Beyond Borders, A Career in Global Oncology, The Power of Partnerships, Advocacy, and Collaboration. And I'm going to tell you how I got where I am. I'm going to encourage you to think outside the box and follow your passion. So here's why I went into oncology. I was an undergraduate, a little bit north of you guys, and I had just met my husband as an undergraduate, and we knew we both wanted to go to med school, but we weren't quite enough in the relationship to say we're going to apply together, but we didn't want to apply apart. So we said, let's take a little time, spend a couple gap years. Believe me, in 1981, we did not do gap years. And let's get jobs. Let's get jobs so we can get exposure to medicine and build our resumes, And so I got a job in an oncology lab. Just that's where the job was, as a lab tech in oncology at Stanford. And these are my first two real mentors. And if you take nothing else away from this, good mentorship is where I got to, and you should look for it as well. So Richard Miller and Ron Levy were in the lab, and I was pipetting. We were making monoclonal antibodies when that became a thing. And I could see we made some antibodies to lymphoma patients that we actually infused patients with. And one of them had an amazing response. And I'm like, this is the coolest thing in the whole world. We can do research, and I can see how it directly translates to patients. And I did have great mentors, and they put me on one of our papers. As a lab tech, I got a paper in the New England Journal of Medicine, a very prestigious journal. So I was committed to oncology. And then I went to med school. I did my residency and ended up back on the West Coast in Seattle, Washington. And this is my mentor, my lab mentor in Seattle, Dr. Mac Cheever. And this really is a real picture of the Fred Hutch. It zoomed in a little to bring Mount Rainier up, but this is what it looks like on the few days of the year when it's sunny. I was still kind of undifferentiated. I was now in an oncology fellowship. I didn't know where I wanted to land. And Mac, when I came into his lab, said, I've got 3 projects with 3 different oncogenes. One of them's in breast cancer, one of them's in lymphoma and all. And I said, I'll take breast cancer. And I started working on this interesting molecule that we were just learning. If it was found on breast cancer, which happens about 20 to 25% of the time, it was really aggressive. These cancers recurred, they spread, they didn't respond to standard treatments, and I was just doing some basic lab work on this and got more and more interested. And Dr. Hurwitz, who will speak later, was part of a group at UCLA that was working on developing this as a target for treatment. But so I said, okay, I'm interested in HER2. I'm going to restrict my clinic to breast cancer, and that's how I got into breast cancer. And then as I got my first faculty position, my mentor, Dr. Robert Livingston, said, let's teach you how to do clinical trials. Because I always thought I'd be like my mentors at Stanford. I could be in the lab, I could see patients, I could do everything, and have a home life. And then I realized I probably needed to restrict myself. So I started to learn how to do clinical trials. I was very lucky to have my professional organization that I'm now the chief medical officer of, ASCO, the American Society of Clinical Oncology, gave me a career development award in 1995 for a project in metastatic breast cancer. And then I joined a big government-sponsored clinical trials group called SWOG, part of the National Clinical Trials Network, funded by our National Cancer Institute. And Dr. Gabe Hortabaji, who spent his career at MD Anderson, was chair of the breast committee. He made me his vice chair. I ultimately became the executive officer over breast and lung cancer. So I had this national clinical trials network. I led a 6,000 patient trial through SWOG. And to design that trial and then have things change so that the standard of care changed, so we had to redesign the trial before it opened and all. It took a long time to do the trial. It ended up being a negative trial, meaning that there was no difference between the different things we were testing, but that's still important to know. But the Journal of Clinical Oncology, the journal of my professional organization, rejected it. So the first idea for this study was in 1999. It didn't open till 2006 because the standard of care kept changing. It finally got published in 2020. So this has perseverance. That's another thing you have to learn. Stick with it. So one of my early career influences was my patients. I took up breast cancer, and my patients would tell me when they were done with their chemotherapy in the early stage setting, okay, now you're saying I've been seeing you every couple weeks or at least once a month. Now you're saying you're not going to see me again for 3 or 4 or 6 months. You're telling me, go and live your life. I need help in this survivorship mode. And that was, back in that era, not something that we paid as much attention to as we do now. And so I started listening and started education and all, and then had the opportunity in 1995. I was approached by Danskin. They had a women's triathlon series. They're sprint triathlons, short distances, and their spokesperson's mother had died of breast cancer. And she made Danskin give free registration to breast cancer patients, along with, if you signed up for it, a couple months of training. And so they found me in Seattle and said, will you nominate some of your patients to do this? And I said, sure. And so they trained, they got a coach, and this is a group of breast cancer patients coming across the finish line in 1995. When we were, the day before, we were at the expo for this triathlon, and the news station, local news station was there, and they were asking all the patients, why are you doing this? And some of them said, because Dr. Gralow thought I could, and I'm like, oh, wow, that's real power, that's real influence. And then they put it in front of me and said, why are you doing this triathlon? And I said, oh, no, I'm not doing it. I'm just here to support my patients. And my patient sitting next to me, who was bald on her chemo, I knew how anemic she was. She looked at me and said, why aren't you doing this? I said, okay. I went out and bought swim goggles, and I did it with them the next day. I was not the fastest. I said, as the team physician, I'll be the sweep crew. I'll follow you. But anyway, as we got to the finish line, they said, this cannot just be a one-time thing. We need this all the time, all of the training, all the camaraderie. So we decided we would form a nonprofit. I didn't know anything about forming nonprofits, but I was young. I didn't sure, let's form a nonprofit for breast cancer patients to get fitness in their lives. And then we quickly decided it should be for all women patients with cancer. And so we had a mountain climbing group and a biking group and a dragon boating group and a group that just did gentle yoga and whatever fit, and wrote my first book with a couple of colleagues, Breast Fitness, and we just celebrated our 30-year anniversary. So it is going strong. So then, mid-career, out of the blue, this was not what I planned to be part of my life, this global stuff. Mid-career, I was asked in the late 90s by a local nonprofit called PATH. At that time, it was the Program for Appropriate Technology in Health. Now they're just PATH, like KFC or whatever. And so they were applying for a USAID grant for breast cancer assistance project in Ukraine. And PATH had a whole network set up of vaccinations in Ukraine post the Soviet era, but they didn't know anything about cancer, so they asked me if I would be the medical oncologist on this project because PATH was based in Seattle. I said, sure, I'm up for it, I'll try it, this sounds interesting. And so that was a 3-year project. And the first thing, we did it in association with the Ukrainian Ministry of Health. The first thing we did was try to figure out what they were doing in breast cancer. And in a post-Soviet era, you would be asked, do you want the official numbers or do you want the real numbers? That was the Soviet era. This picture over on the right is a tile mosaic. It's still outside the National Cancer Institute in Kyiv. It is the whole team that is fighting the crab. I love this teamwork approach of fighting the crab. I used to put this in my talks for med students and residents and all, and I'd say, so who do you think this person is at the center that's directing the beam of light? And of course, the radiation oncology resident said, that's obviously a radiation oncologist because that's radiation. But the med students would get it right. They'd go, I think that's the patient who's in charge in the middle. So anyway, so the first thing we did was assess what was going on. I was met the first time I went over there by a news crew and a reporter. They stuck the microphone in front of me. I had an interpreter, and they said, tell us about this American project, but don't use the word breast and don't use the word cancer. So I turned to my interpreter and said, it's on you. You figure out how to explain this. So they didn't talk about it. And that was totally, if you've ever read Solzhenitsyn's Cancer Ward or The Experience, they were taught in that era, if you give a patient a potentially life-threatening diagnosis, they'll lose all hope, they might commit suicide, you don't talk about it. So they were not talking about it. Treatment, as we discovered, was just based on what drugs they had. It had nothing to do with evidence or science or what worked. The number of cases treated, the exact regimens they used, was very difficult to determine. And what we found when we really went in detail and gained some trust in a relationship was they used very low doses of chemo because they didn't have enough. So they just split it to the point where chemo in an effective dose that would normally cause hair loss, you would see women getting this chemo and they wouldn't be losing their hair. And you're like, what kind of dose are you giving? This is not the dose that's effective. And they said it's because Ukrainian women can't tolerate Western doses of chemo. And so one of my contributions to the project was I partnered with a chemotherapist, that's what they called medical oncologists back then, in Odessa and her team, and I said, let's prove to the surgeons that chemo can work in breast cancer. Most of their cancers were late stage. The surgeons were operating even though there was no chance with these big tumors. They were getting clear margins, et cetera. So I said, let's give some chemo before surgery and show the surgeons how much it shrinks, and then they'll gain respect for chemo and maybe refer more and want to partner with you. So we did a preoperative chemotherapy trial. These are the study booklets for all the patients. We got it approved by a couple different institutional review boards. And what happened was, in many cases, the tumor shrunk so much that the surgeons said, oh, I don't think I need to operate now. And I'm like, that was not the point. You can't see the microscopic disease, but don't you think it works? And so it gained the status of the chemotherapists, and it helped the relationship between the surgeons who saw if you shrink the tumor, the surgery is much easier, actually. So that was my contribution. We also had a breast imaging project up in Chernihiv, which is the oblast that Chernobyl's in. and it was on public awareness, so we offered some screening mammograms to the public, but we forgot to budget for the film. And so patients had to bring their own film, which is why there's only 3 out of a typical 4 films here. But these guys, the Soviet era, these guys, they know how to get things. So they would come with unexposed film and bring it. And so here we are with that project. The project that has had the most lasting value was our psychosocial support project, and it was the School of Nursing. We had some faculty from the School of Nursing on this project, and they were exploring that don't say the word. They're like, how can you be giving informed consent for a treatment if you don't even get told your diagnosis or have the opportunity to talk about it? And even though patients would be in a cancer ward on a chemotherapy unit, they would say, I have cancer, don't I? And they'd be told, no, you just have a very bad infection, so we're going to need to remove your breast. And then we're going to give you really potent antibiotics that are going to maybe make your hair fall out. I mean, they knew they had cancer. They were in a cancer hospital on a chemo ward, and they didn't have any opportunity to talk about it with other patients, with their nurses, with their doctors. So we went in, we did some exchange visits, and we said, we found a couple nurses, a couple doctors, and a couple patients who said they were interested in exploring how do you talk about this. And so that was a very important project, and they helped us develop educational materials for patients and survivor support and stuff. So over on the left, you see the ward. These are patients with breast cancer, no support system. That was 97. Between this 97 and 2000, which was the period of this award, we had this project going on. And by the end of 2000, we had survivor groups that started. And they call themselves the Amazonki because after the mythologic Amazonian women that cut off one breast to better shoot the bow and arrow. And they organized a first March for Life and Hope on Kreshadok Street, the main street in Kyiv. In the post-Soviet era, to get permission to do a march in the middle of a major city was amazing. They got permission, and a march is a real marching band. That was their interpretation. And they said, we're doing this for our daughters. And they had, by 2001, we had branches of the Amazonki across 15 oblasts, kind of states or counties within Ukraine. And then the project ended, and I said, if I'm in the area, I'll come back and visit you. And I then got the opportunity just a couple years later, in 2003, I traveled with another Seattle-based group called the Center for Women and Democracy, and we did an exchange visit of business and professional women in Seattle. We partnered with another group of business and professional women in Sweden, and we went to the Baltic countries, Lithuania, Latvia. And so I said, I'm coming to Lithuania. I said this to the breast cancer support groups in Ukraine. What if I'll pay for you to come, and we'll invite some breast cancer support groups from across other former Soviet states, and let's all meet at the end of my trip with the Center for Women and Democracy, and you can just share what's working and what's not. And so Agnė Zawakine, standing in the middle there, she was the head of the Lithuanian breast cancer support group, and she surprised us all by unveiling this van in front of the hotel for our meeting. It was shrink-wrapped. It has a pink ribbon. It says Nedalsk. That was the name of her nonprofit. It means don't wait in Lithuanian. All of this, the van, the gas, there was trinkets. They would drive it around to the countryside, and women would be attracted to the van. They'd give them little gifts. They actually had a physician that went, so women would come and talk if they had a symptom or something. They'd learn about breast health, cervical health, et cetera. And so she unveiled this, and it was 100% on donations. So I don't know if you guys have heard the term. It's a big global term, a non-governmental organization, an NGO. Well, that term was very relevant in this era because everything in the Soviet Union was governmental. So the thought that you, with a non-governmental organization, could do something like this was a revelation. It was a total revelation to these women. She went out and got donations, and so this is pictures from that first group, and then we came up with a classy name for what we called what we were doing, the Women's Empowerment Cancer Advocacy Network. And it started in Eastern Europe, Central Asia. I founded it in 2003. And it was all about empowering, connecting, and educating breast, and then we added cervical cancer patients, advocates, in order to improve cancer outcomes in their own countries and regions. And so our mission was to combat cancer by building advocacy groups with the skills to address inadequacy in information, inequity in treatment and care, and injustice in breast and cervical cancer early detection, screening, and prevention. So our second weekend meeting, 2 years later, we went back to Ukraine. And this time I got to participate in the March for Life and Hope. It was a big group, and again, brought some of my colleagues from the Center for Women and Democracy to see what this was all about. And this is the group of advocates from about 12 former Soviet countries. The third one we did another 2 years later, and we picked Belarus. They reached out as a nonprofit and said, we'd like to host the next one. And so they could not get a permit to do a march in Belarus. And so the US ambassador, Karen Stewart, to Belarus said, I have an idea. We're going to have the conference in this hotel. Let's pick a restaurant for our gala dinner that's across this park, and we'll all walk as a group over to the restaurant. And anytime there's congregation of anybody in Belarus, people would go, what's going on? Because it wasn't like allowed. And so indeed, here we are, led by Ambassador Stewart, doing the march, and lots of people said, what are you doing? Where are you going? And I just really love this. So at the end of each of these, the group that hosted it is supposed to do a report. So In Rays of Hope was the name of the breast cancer advocacy group in Belarus. And they wrote, the Breast Cancer Advocacy Conference in Minsk was a momentous occasion in grassroots activism. By coming together with a passion to combat the impact of breast cancer, conference participants set a course to change how the issue will be recognized at all levels. As a result, breast cancer early detection, screening, and prevention will become a national priority in Belarus, and by inviting international participants, the conference planted seeds for similar grassroots mobilization efforts throughout the former Soviet Union. I mean, this is like a little thing that started with me saying yes, and I'll go to Ukraine. Like, you know, I'm like, wow, all it takes is just a little bit of push, and look at, we're like really doing something. The fourth one, in 2009, we went to Bishkek, Kyrgyzstan. And this is some of the Ergeni group that hosted it. We had a lot more participants. I, through a friend of a friend, had been connected with a parliamentarian, Rosa Otunbayeva, and so she said, I want to be at the conference. I have an announcement to make. I'll get us some press. And I didn't know what she was planning, but this was over in the upper right. This was a famous Kyrgyz ballerina during the Soviet era who died at a very young age, and they never talked about why she died. And this statue was right outside the hotel I was staying at. So we had a press conference, and she announced to the press, did you know she died of breast cancer? And so it made the headlines. This was a beloved ballerina. And we got a lot of press out of this. And it turns out that after we left, a couple months later, they had a revolution, and now Rosa was the interim president of the country. So it helps to have friends of friends, too. But here over on the bottom right, Kazakhstan drove and showed up with a van that they had modeled after that Lithuanian van. And they said, we're a big country, so we have 3 vans. But so they're sharing their best practices and their ideas, and they had gone out and gotten it totally paid for with non-governmental funds. Few more conferences in between, but now we're in Tbilisi, Georgia, for our 6th conference. Here's the group. And we got the U.S. ambassador to Georgia to come, Richard Norland. And here, this is a direct quote from what he said at the dinner. He said, by bringing together attendees unified in a common cause, cancer, this summit has done more to bring dialogue, diplomacy, and consensus to the region than any meeting I have ever attended. Breast cancer as a basis for diplomacy. We got people, we had Russians with Ukrainians, with Armenians, with Georgians, with Azerbaijanis. They were all fighting each other in various ways, but everybody was there for cancer and they got along. And then we even had the First Lady at the time come and do a little walk with us to celebrate and create cancer awareness, Sandra Roloffs. So this is the summary of all the different weekend meetings that we had in Eastern Europe and Central Asia over time. And then the pandemic hit, the war broke out in Ukraine, and you'll hear in a minute, then I took a new job. And this was not its own nonprofit. I housed this in the University of Washington is how I fundraised for it. And so when I left the University of Washington, retired from the University of Washington, I said to them, well, first of all, the pandemic has to end, and I can't go back to Ukraine right now during the war, but I will help you. We will stay in touch, and we have. As part of all of this, I started getting really interested in global oncology, and I was asked to join a group called the Global Task Force on Expanded Access to Cancer Care and Control in Developing Countries, and the secretariat was housed in the Harvard School of Public Health. It helped that one of my patients' husband was the dean of the Harvard School of Public Health at the time that I got appointed this. He's now the chancellor at UCLA, by the way, Julio Frank. And so we published, Paul Farmer, who you may know founded Partners in Health, was the lead author on this publication in The Lancet on expansion of cancer care and control in countries of low and middle income, a call to action. Wrote my second book, Closing the Cancer Divide, an Equity Imperative, and Felicia Nall, my patient, friend, partner, colleague, led all of this, and Princess Dina Mirid was our voice publicly. She's in Jordan, speaking at the UN on the topic. So I'm doing all this. I'm doing my day job. I'm leading a breast program. I'm the executive officer in a major clinical trials group. And then I was asked by colleagues in Uganda, because the Fred Hutch has a very strong relationship with the Uganda Cancer Institute. They were founded mostly on grants based on HIV-related malignancies, but they said, but breast cancer is really common here, and they want a breast cancer doc to come. So even though our funding is on HIV-associated malignancies, which breast cancer is not, will you come and do some teaching, talk about doing some trials in Uganda? And so you'll get the theme. I said, yeah, that sounds interesting, and I agreed to go. And but this relationship between the Fred Hutch and the Uganda Cancer Institute was built on an infectious disease model, but tied to cancer, and it had components of clinical care, training, and research. We partnered to help them develop an adult hematology oncology program. Here's the first class of fellows there that I was proud to teach in. And they came, we had reciprocal visits, and they came and saw our multidisciplinary breast clinic, and they went back and started their own multidisciplinary breast clinic, and here they are at a tumor board, and they invited me to be at their first multidisciplinary breast cancer tumor board. So a nice partnership. A big part of what we did, my global oncology team did when we went into Uganda, was we needed to understand patients' attitudes and perceptions about cancer. And we went in and did focus groups in clinics of women showing up to a clinic for, not a cancer clinic, just general clinics. And we wanted to ask them, what do you think about cancer? And what we heard repeatedly was they never knew anybody who was diagnosed with cancer who survived. Anybody who went to the Uganda Cancer Institute didn't come back. They didn't know a single survivor. So why would you, if you had a little tiny lump that wasn't causing any problems, why would you spend your money for food for the week to take the bus to come into a clinic if you didn't think it mattered? You'd wait until it was causing symptoms, which is not the right time that we want cancer patients to show up. We also thought we could do some education. There are a lot of HIV and TB community health workers. This is a little village in northern Uganda, Aminachera, where these are the community health workers, and we're teaching them about what are some of the basic things about breast health, cervical cancer health, and screening that you should be teaching out in the villages. And then as we started our weekend work in Uganda, we needed to understand the health system, who were the respected providers within the structure. And so this is a traditional healer with a gynecologic oncologist. You probably can't even look at them and tell who is who, but we had them partner together in talking about how to get the best outcomes for our patients. Whoops. So quickly, my first visit to Uganda, I was approached by these women, the Uganda Women's Cancer Support Organization, UWACASA, and they said, can you do what you did in the former Soviet Union in East Africa? I said, can we? I think it'll look a lot different, but if you want to help lead the way, let's figure it out. So they were very willing to show the community that breast cancer is survivable. These were brave women who were willing to go on the radio, go on TV, and say, I was diagnosed with cancer. I am here today. Look, I'm healthy. My husband did not leave me. My husband did not take a second wife, which was also common. They provided awareness, supportive care. They could advocate for diagnosis and treatment. And so we started a series of East and Southern Africa breast and cervical cancer advocacy conferences. You can't see where they are. It got somehow minimized with the conversion. But these are very colorful. So they were very different in terms of the outfits people wore and how they interacted and what their main barriers were. But we held a series of weekend conferences. The last one, as soon as the pandemic ended, we did one in Malawi that had been planned from before the pandemic. And then I told them, you guys are ready to do this on your own. I'll be there, I'll help you, but I'll meet you regularly, but you should take this and run with it, which they are doing, and I'm incredibly, incredibly proud of them. And this just tells you the story of patient advocacy and partnering with patients. Here's one of the women in this photo is Gertrude Nakaguti, who was the leader of this group, but she had a full-time job because they didn't have enough money to pay her. She was an accountant. And at one of our weekend conferences, we had $5,000 left over. So we said to the group, we're going to do a little grant competition, and we'll give 5 $1,000 grants. You write the grant, you tell us what you'll do with the $1,000 to raise awareness of breast and cervical cancer in your country, and then you'll learn grant writing skills, we'll support you, and then we'll do follow-up. And so Gertrude wrote a grant. What the Ugandans said was, we're going to take the female parliamentarians out to lunch, and we're going to talk to them about breast and cervical cancer so they can advocate for us. And so they wrote that, they got it, it was successful, and then they said, we can write a grant. And so then they applied to the Union for National Cancer Control for a metastatic breast cancer grant, and they got it. And then Gertrude, they had enough funding so that Gertrude could quit her day job and be a full-time executive director. And here she is with her son. And this is the SPARK grant that they got in 2016 from the UICC. And here they are speaking to Parliament. And in 2018, Gertrude became a board of director member of the Uganda Cancer Institute because of the respect that the Cancer Institute had for bringing patient advocates to the table. That's the power of patient advocacy and the power of supporting patient advocates to have a voice. So then the pandemic happened, and I was looking toward my succession plan, who's going to take over all my different roles. I was planning on riding out my career at the University of Washington and the Fred Hutchinson Cancer Center. But in 2020, this job opened up. There was this article that said, we're searching for a new chief medical officer. And I looked at it, my predecessor was retiring, and I said, this would be a great job for somebody. and didn't even think about it. It was going to be hard after 30 years for me to think about moving from Seattle or whatever. But I actually had a couple of my mentees who were now at other institutions start emailing and texting me saying, this is you. They want to grow global oncology, but they need a thought leader, a respected thought leader. They need somebody who's a clinical trialist. This is you. So it was very interesting, the backwards now, that my mentees were telling me, you should go for this one. So I did. And I became the chief medical officer. And this is one of the articles in the upper right. ASCO's new CMO, Julie Gralow, will focus on equity, advocacy, and global health. And as part of my role, I am I lead press for all of our clinical issues. I testify in Congress. This is testifying on drug shortages, and testified about the implications of Roe v. Wade, and get invited to the White House. Here's an event, the White House Africa Cancer Forum. I have a really good job. It's really interesting. And this is our society. Deanna, you said we have 45,000 members. We actually have over 50,000 members now in 170 countries. About 60% are US-based, but 40% are international. Members and training are free. You can become an ASCO member as a trainee for free if you are interested. And then we made members in low and lower middle income countries could become members for free. We decided as I was joining that we needed to not just go out and offer things to rest of world, but form regional councils to hear what they wanted from us. So we now have regional councils. Our first was Asia Pacific, then Latin America, Sub-Saharan Africa, Central and Eastern Europe, and we formed an India advisory group because that's now that we have membership free in low and lower middle income countries. India is number 2 in our membership. They bumped Canada to number 3. So we have memorandum of understanding with a lot of other organizations. We've got a memorandum of understanding with the National Cancer Grid of India. We support, this is a clinical trials training workshop in Mumbai that this is the year I went, 2024. We've been supporting, we send a couple speakers, and they train about 80 over a week period where you're in this resort with nothing around you, so you can't leave. You have to pay attention and be there. It's a great workshop. We have a partnership with the African Organization on Research and Training in Cancer Aortic, and a lot of that is about clinical research training and career development. And one of our more recent memorandum of understanding is with the Egypt Cancer Society, where we're focused on quality cancer care and research. We're using them as a hub in the Middle East and North Africa region while we try to figure out how to have a potential regional council in the region, and that's complicated. We partner with organizations like the Union for International Cancer Care. This is our ATOM coalition, which stands for Access to Oncology Medicines. It's led by UACC, but ASCO is a member in education, capacity building, guidelines development, quality care. We have about 46 target countries ultimately. We have 10 capacity building countries, and the first 3 are launching: Mongolia, Zambia, and Honduras, with Uganda and El Salvador right behind. What we're doing is we're getting drugs on the World Health Organization's essential medicines list available, and also some of the targeted therapies that are very high reward that are becoming part of the WHO essential medicines list. But you can't just get the drug, is the whole point here. You have to know how to use it. You have to have the capacity to deliver it. You have to be able to manage the toxicities. And with precision oncology, you have to have the diagnostics that tell you what drug is going to work and who. So it's much more complicated than just getting drugs. We partner with City Cancer Challenge. This is partnering not at a country level, but at a city level. The whole government has to sign on, and the local hospitals and the clinicians in the area, as well as the patient advocacy group. And so these are cities that have applied and become City Cancer Challenge cities. And our partnership here is also in training, capacity building. Here we are at a multidisciplinary cancer management course on breast and cervical cancer in Peru. My favorite part of our relationship with City Cancer Challenge is what we call our leadership program for women in oncology. So one woman from each of those cities was invited. We're now in our second cohort to participate in this leadership program. And here we are with the first cohort. Here they are in Geneva meeting, and then I'm meeting with them at our annual meeting in Chicago, and I'm just so proud of them. They are so amazing. And so here's a little, we had this running joke that the first, when we were in Geneva at our very first meeting of this group, we were invited to some ambassador's residence or something who was hosting them, and the door, we couldn't get it open. It was just so heavy. We thought it was locked, and so we had this joke about a heavy door, right? So then, right next door to my apartment in Alexandria, I live in Seattle, but I work in DC. I took this picture. We're open. We are open. The door is just very heavy. And so this was a tweet somebody put about academia to women in academia. We are open. The door is just heavy. And so then somebody replied, if you do manage to get the door open, make sure you hold it open for the women behind you. Better yet, once in a position of power, rip out that heavy old door and put in one that opens automatically. So this became our theme. And so then we were meeting again in Senegal. And of course, there was a very heavy door sign. So we jokingly, here I am with a couple of the leadership program for women in oncology, women from Africa, and then one of my staff behind them. So I'm like leading them through the door and my staff is holding it open for them. So this is our running theme. We have to support each other. And of course, my relationship with all my colleagues and the patient advocates in Ukraine came into play when the war broke out in Ukraine. This is a piece I wrote for the Cancer Letter right after the Russian invasion, when I had tears in my eyes, reflecting on 25 years of collaboration and friendship with cancer patients and physicians in Ukraine. And we started and joined with many other organizations a network on cancer and crisis, and this is all part of our work with our special network on the impact of the war in Ukraine on cancer. It's broadened to a World Health Organization, cancer and crisis more broadly. There are lots of parts of the world that are in conflict. And we put out a manifesto on improving cancer care in conflict-impacted populations. The first author, Dr. Tedros Ghebreyesus, is the UN Director General, first time and last time, I'm sure, that I've ever been a co-author on a paper with the UN Director General. But we have expanded this well beyond Ukraine, where we still have a lot of interest, but to everywhere that there's conflict or crisis. So then, to end, moving into my late career, I'm now the mentor, the sponsor, the ally. My job isn't to develop my career anymore. It's to support all of your career developments. Here I am with some of my mentees and trainees. Terry, you're in at least one, if not two of these pictures. This is my job now. This is why I say yes when Deanna asks me to come. And I reflect back, and I didn't really show you any formal female mentors, but I had plenty of female role models. Here are two of my chief residents when I was doing my internal medicine residency in Boston. And then in Seattle, two of my mentors are now former president at the University of Washington. She just retired, Anna Marikowski. She's my neighbor at our island house, and we get to go on long walks and talk about amazing things. And she is, by the way, a very unusual university president. First of all, she came from within, which is not common. Secondly, she's female. She is Cuban-American, born in Cuba. And third, she's lesbian. So this is Seattle. You know, we strive for differences. And then Dr. Mary Claire King, I met right after she came from Berkeley to Seattle, she discovered the BRCA1 gene and it's related. Everybody fought her, and no, cancer is not inherited way back in the day. And she and I have became close friends in basically being disruptors and fighting the system. And I'm very proud. I did get an award from a group a couple years ago, Lifetime Disruptor Award. Proud to partner in the Lancet Commission on Women, Power, and Cancer, led by my colleague Ophira Ginsburg, looking at all the roles that women in society play with respect to cancer, not just being cancer patients, but by being caregivers, by being professionals, researchers, patient advocates, et cetera. And most recently, as a result of the global moonshot work that started a couple years ago on can we develop a global cancer fund or a global cancer financing platform modeled along the lines of the Global Fund for AIDS, TB, and Malaria, which has done so much good in the world. So the global moonshot team held a meeting with about 100 stakeholders at the White House in October 2024 on can we build a global cancer fund? And then following the election, but before the change in administrations, a small group of us went back to the White House to say, can we keep this momentum going in this era that's about to start? And so we committed to it. And I'm very proud to say that that ASCO has been able to serve, I'm calling it an incubator role, where we have contracted with the head of the Global Moonshot team, who was leading all this work, Catherine Young, and we've gotten support donations to pay the salary of her for a 2-year period to help work on developing this Global Cancer Fund. We're working with World Bank, WHO, other professional societies, many more than this. These are the ones that have contributed salary support. And then we were able to launch a global cancer financing platform as a side event at the UN General Assembly in September in New York. And we partnered with Bloomberg, and they have a New Economies International Cancer Coalition and ASCO. We had a side event during the UN General Assembly, and we invited ministers of health that were in town for the UN General Assembly, ambassadors, et cetera, and we talked about what this platform could look like. And our pilot is the Ugandan ambassador to the US, Dr. Ruby Kakonge, announced that Uganda would take the lead and do the first pilot. What this whole financing platform, especially in this era, was we cannot be taking money from any other global organization. We need to find new untapped sources of funding in this era. So we looked, we've got people who are much smarter in finance than I am, and so the launch of the first pilot project will be looking at diaspora remittances. Very, very interesting. There are billions of dollars that come from the diaspora, from Africa and other countries, that go back to these countries again, to help either the families or the country, et cetera. And so we thought about, could we tax the remittance a little bit, or could we tax the remittance company a little bit? In the end, it's a diaspora bonds that are guaranteed by the Bank of Uganda, where they're investing with these remittances in cancer care. It's much more well-developed than I'm saying, but they've launched it. And they just on January 29th had a big event at the Ugandan ambassador's house in DC to launch this. And this just tells you about the remittances. So remittances back to low and middle income countries are more than $660 billion in 2023. Africa got $100 billion. If you could just get 1% out of that, that would be $1 billion a year that you could do. We're focusing on breast and cervical cancer and on earlier detection. So these are the goals. Those are best buys. You bring in early, you get higher chances of cure. So to conclude, I didn't lead a real conventional path. And what I frequently heard from my division directors, department chairs, administrators, and others are, you're out of the country too much. if I were infectious disease doc, nobody would have said that to me, but I'm an oncologist, and there wasn't really a path for that. And my reply was, I am the best at answering my emails, better than any of my faculty. My patients don't complain, that they can't get me. My nurse doesn't complain that she can't get me. My colleagues don't complain that I'm asking them to cover my clinics too much or anything. So what's your point? And I actually then took that, and before I joined ASCO, in my prior life, I led a task force to try to turn academic global oncology into a viable career pathway. So this is recommendations from our academic global oncology task force back to institutions on how can you help support a career path in global oncology. I also heard you shouldn't be interacting with your patients outside of clinic. And one of them's turned sideways. But I love the shirt that I'm wearing in the middle there in the upper right. When was the last time you did something for the first time? So don't be afraid to do things for the first time. I got the love of mountain climbing from Team Survivor. And I'll end by saying, you've got to stay balanced, too. I mean, work hard, play hard has always been my model. You've got to nurture the soul and stay balanced. I mean, my interactions with patients and my global stuff, those are the things I'm most proud of and I get the most satisfaction out of in my whole career. So celebrate the milestones. Block off time. Early on, my husband and I had to sync our calendars, and I would promise what weekends I would be in town. And we actually committed to buying a little island house that we could go to and just like be away on weekends and things. And that was really important. And I'm so glad we did that. So celebrating milestones. So for my 50th birthday, I got together 6 friends. 3 of us were Stanford undergrads together. We were all turning 50. And I said, who wants to climb Mount Kilimanjaro? And I got 6 friends to do it, and here we are at the top. I'm pretty out of breath right there. And for my 60th birthday, I went to some other couples and said, who wants to go trekking in Bhutan for our 60th birthday? And so here we are, 4 couples trekking in Bhutan. I decided, as part of a cancer fundraiser with a group of radiation oncologists who like to climb mountains, but they also are interested in global oncology, to commit to fundraising on a climb to Everest Base Camp. Seemed like a good idea. I was also very out of breath in this picture. Did the New York City Marathon as a fundraiser for breast cancer, celebrating. This is our family time on San Juan Island, which is our island house with our 3rd dog, and my husband and I just celebrated our 40th wedding anniversary now, so we've had 3 dogs over that time. Trip to Patagonia, Chile, ziplining with my nephews, and for my 65th birthday, I decided to be a little less athletic, but go to Antarctica. So here's a picture my husband took in Antarctica for our 65th birthday. And I'll end just with the title, Beyond Borders, A Career in Global Oncology. Partner, advocate, collaborate. Do what nurtures your soul, and you will be happy. Say yes, try new things. And even if your bosses are saying, you shouldn't be partnering with patients or you're out of town too much, make sure you're not, that you're doing it well and that people don't have things to complain about, and just do what nurtures your soul. So with that, I'm going to turn it over. I'm going to turn it over to my patient, my partner and work, my friend, Terry Pilastro. I'm not going to tell you her story, but I'm going to let her tell you the story of how we've worked together and partnered. And Terry, thank you. Thank you so much for being here.
Thank you. Okay. Hi, everybody. I'm so honored to be here. I can't thank you enough for inviting me and making me feel so welcome. So, the year was 1999. I'm dating myself. I had just given birth to my second daughter, and I was diagnosed with early stage breast cancer. To put it simply, I was terrified. Women my age didn't get breast cancer. I learned of this rock star oncologist. Everyone kept telling me I absolutely had to see for my second opinion. Dr. Julie Gralow was already making waves in global oncology, jetting around the world. I remember her walking into my room and thinking, oh my gosh, she's brilliant, she's accomplished, she's personable, and she's beautiful. This just doesn't seem fair. I continued my care at my original clinic, but happiness was not part of that treatment plan for me. When I'd ask questions about my future, could I have another baby? Would I be eligible for hormone therapy? My oncologist would literally roll his eyes at me, as if hoping for a future was somehow misguided. I'd come to appointments armed with my carefully prepared list of questions, and he'd wave them away with a patronizing, don't worry about it, you're cured, go live your life. Which sounds nice until you realize he was essentially saying, stop bothering me with your pesky questions. After 4 years of that, I told my husband, that's it, he's rolled his eyes at me for the last time. I'm going back to that hotshot oncologist from 1999. Lesson: when you are the patient, listen to your gut. So, in 2003, 4 years after my original breast cancer diagnosis, I had my first appointment with Dr. Gralow as my new oncologist. We both thought this would be simple. Discuss my care, maybe transition to the wellness clinic in a year, easy peasy. Then Dr. Gralow explained how her practice worked and that she'd run some standard blood tests plus something called tumor markers. She explained they weren't part of standard care because sometimes they gave false positives. I agreed to add them to my lab work and promptly forgot about it. We were leaving for a family ski trip to Canada the next day, and I had more important things to think about, like if I'd packed enough snacks for my kids. 5 days later, as we crossed the border back into the United States, my phone started exploding with messages from her office. After several scans and a biopsy, Dr. Gralow called me from Europe to tell me I had metastatic breast cancer. It had spread to my liver. She apologized for not calling me the day before. The time difference meant she couldn't give me the attention I deserved. She said, I found that statement so truthful and refreshing as a patient. My doctor was a person. She was like a human being, like everybody else. That moment was the foundation of everything that came after. Here was this internationally renowned oncologist calling me from another continent and apologizing because she wanted to make sure she could be fully present for the worst news of my life. And here's the funny part, or maybe it's the anxious part, as you saw earlier, but after that phone call, I became completely obsessed with Dr. Gralow's travel schedule. I don't know if you remember this. During our appointments, she'd always have to tell me where she was going, how long she'd be gone, when she'd get back, and how I could reach her. I never once needed to reach her while she was traveling, not once, but knowing I could, that was everything. Of course, I had all kinds of sideline doubters telling me we should be doing things differently. When we met with Dr. Gralow, we would pepper her with questions, comments, suggestions, and criticisms. She always listened, answered them, and reassured me we were on the right track. And if we were not, we would look at other options. Patients need that sense of security initially. As time goes on and they learn the cancer system, They need less hand-holding, but in those early days, knowing that I could reach her was like having a security blanket. I never actually used, but desperately needed. Lesson: patients need security when they are facing a life-changing diagnosis. Words that became my lifeline. I don't know if you'll remember any of this. I think it's so funny in a sense. There were a few things that Dr. Gralow said to me shortly after my diagnosis that I repeated to myself over and over again. I was a young mom, terrified, and I would die before my children even got to know who I was. My first question: am I stage 4? Her response: you are stage 4, but they need a stage 5 because people are living longer and longer. Lesson: this is the art of giving hope without giving false hope. Question: how long will I live with this disease? Her response: the statistics are not good, but you are not a statistic. You are young, healthy, strong, and you've never had chemotherapy. Over time, she shared that our birthdays were one day apart. We would always wish each other a happy birthday, and we both celebrated that I was still alive. I'm not sure either of us thought I'd be alive and well 23 years later, but here we are. Lesson: she gave me permission to see myself outside the numbers. Question: what happens if I don't respond to the treatment? Her response: we just need this treatment to work until we have another one in our back pocket. Our goal is to push you out until the next treatment is available. Thank God for research. Then she'd tell me about drugs and clinical trials approaching FDA approval. Lesson: she gave me a roadmap when all I could see was a dead end. Question: how am I going to tell my 7-year-old? Dr. Gralow referred me to an excellent psychologist at the center. I was so afraid I'd break down during the conversation that we decided to role play. I practiced my spiel with my psychologist until I felt ready. Shortly after the moment came, my daughter and I were taking a bath together. I explained that I had cancer and needed medicine that would make my hair fall out. Then came the question I'd been dreading: are you going to die? My practiced answer: I'm not dying right now, but if anything changes, you'll be the first to know. My daughter seemed to accept this. She pulled the goggles down over her eyes, went underwater, and I thought, nailed it. Years later, she told me what really happened in that moment. When she went underwater, she screamed so I couldn't hear her. Lesson: so much for best laid plans. When my husband and I went to appointments, we always brought our list of questions. Dr. Gralow listened intently. She answered sincerely. She gave us the time we needed. When my appointments were delayed, I never felt frustrated. I knew another patient was getting that same gift of time, that same quality of attention. Someone else needed to go over their questions, and Dr. Gralow was giving them what they deserved. Lesson: when you first meet patients, listen to them. I mean, really listen to them. This is how you meet them where they are. From patient to advocate. My cancer responded well to treatment, but I was still spending a lot of time at Fred Hutch, infusion center, clinic, diagnostics, and I started noticing inefficiencies. So naturally, I started making suggestions to Dr. Gralow about how they might streamline things. And I started seeing some of my suggestions implemented. Dr. Gralow began asking me what I thought about certain things from a patient perspective. One day she asked me if I'd be interested in volunteering in the twice-weekly tumor boards where patients met with an oncologist, a radiation oncologist, a surgeon, and a fellow breast cancer patient. When Dr. Gralow submitted my name, she was told I wasn't eligible. I was a stage 4 patient. I might scare people. That was the wrong thing to say to Julie Gralow. Within days, I started my volunteer role. The first thing I asked her was, how do I determine what to share with patients? She told me, you will learn to meet them where they are. That statement changed how I saw everything. To this day, when I meet with newly diagnosed patients, I always try to meet them where they are. After several years of volunteering, Dr. Gralow asked me if I'd serve as a patient advocate for the University of Washington and the Translational Breast Cancer Research Consortium. I could barely say that name. I had no idea what that meant. I didn't even know what a patient advocate was. It was a steep learning curve. I did not have a background in biology. Sitting with some of the top breast cancer professionals in the country while they designed and implemented clinical trials, but slowly, surely, I found my voice. I started asking questions, admitting when I didn't understand. I couldn't get past all their acronyms, so I made my own little cheat sheet. I found advocate mentors who helped me develop the tools I needed to be effective. As time went on, my appointments with Dr. Gralow became less about my health and more about other things. I knew I was doing well, and I didn't want to waste that opportunity to gain her insights. During one appointment, I mentioned that patients were going elsewhere for care because they wanted to be seen now, not in 2 weeks. Other Seattle centers could get patients in within days. I believe that conversation was the catalyst for a new clinic, the Now Clinic, where patients could be seen within days. Listen, this is the doctor-patient relationship at its best. This is partnership. I was sad when Dr. Gralow left for her new position at ASCO, but I was also excited for her. She told me she'd given each patient a lot of thought, and she felt she matched them appropriately with a new oncologist. Then she said, "You'll be seeing a man." I bristled. I didn't like that. But she reassured me, no ego, no defensiveness. She said, just give him a chance, and if it wasn't a match, I could change. Well, I'm still with that male oncologist 5 years later. He's been my oncologist ever since. It was a perfect match. And listen, Dr. Gralow knew exactly what I needed. She made a perfect match for me. 23 years ago, a doctor called me from Europe to deliver the worst news of my life, and in doing so, she showed me what true patient care looks like. She always listened. She gave me hope without false promises. She helped me find my voice. And she taught me, and I hope she's taught all of you, that the best medicine happens when we meet patients where they are. Thank you.
Well, I just have to say that was absolutely beautiful. Thank you so much for sharing, Terry. Can we please just have one more round of applause for Dr. Gralow and Terry? Amazing. Thank you. Well, I cannot think of a more inspiring way to begin our morning, and I hope we carry their stories with us throughout the day as the ultimate example of why we're here. To honor the work being done to change patients' lives, and most importantly, to honor the patients themselves. So it is now my honor to introduce our Leaders in Drug Development panel. Throughout our discussion, I invite you to submit questions using the QR code on the screen, as well as the back of your programs. And with that, please join me in welcoming to the stage Drs. Sarah Hurvitz, Andrew McKenzie, Lindsay Murphy, and Shayvar Ashuri. Hi, wonderful. Well, okay, let's try it again. Okay, perfect. Wonderful. Well, thank you all, first of all, for being here today. We're so thrilled to host you. I'm really excited for our guests and our attendees, our students, to learn from all your wisdom you're going to share with us today. So I'd love to just start off to begin. Could I please have each of you briefly introduce yourselves and share your role?
Hi, I'm Sarah Hurvitz. I'm a medical oncologist who specializes in breast cancer. I joined the University of Washington Fred Hutch Cancer Center in 2023, shortly after Julie left, and her presence is still felt there, I have to say. I'm the division head of hematology oncology there and the senior vice president of clinical research division. Most of my career was spent at UCLA. I started there in 1999 and was there for until 2023, treating breast cancer. So it's nice to be home.
Hi, I'm Andy McKenzie. I work at SCRI with Deanna, for Deanna. I need to be very specific about that. I've been there for 10 years, and I lead the personalized medicine program there. Before we get kicked off too far here, I just want to say thank you all for coming and being a part of this. And also, I just want to say, if I were an undergrad, there's no chance that I could have put on something like this. And hearing Dr. Gralow's story and hearing Madison and the folks that have helped organize this, I'm just kind of blown away by all of this. So thank you all for coming and being a part. Madison, thanks for being a part here. My background is in cancer cell biology and pharmacology, so I got a PhD in that several years ago, and did a research fellowship at Vanderbilt before starting at SCRI. And like I said, I've been there for 10 years. I'm excited to chat with you all today, and I'm excited for this panel.
Hello. Okay. Hi, everyone. My name is Lindsay Murphy. I'm a proud Pepperdine alum, class of 2010, and I'm a pediatric oncologist. I specialize in treating relapsed and refractory pediatric leukemias. I work at City of Hope, just across town, and I'm a clinical trialist. So we really focus on bringing, new drug therapies to pediatric patients who, have been refractory or relapsed after standard of care therapies. And I have a big passion for research. It was all born here at Pepperdine. And so thank you for having me. I'm looking forward to talking with you all today.
Good morning. I'm Shay Ashuri. I'm a medical oncologist at UCLA, and I practice primarily in Westlake Village. Use Los Robles all the time. So I'm very underqualified to be with this panel because these guys are all genius researchers, and I'm just a lowly clinician that sees patients. But thank you very much for coming this morning. Hopefully you're going to learn a lot, and appreciate you for having me.
Thank you so much for those lovely introductions. I think now that we're all acquainted, I'd love, Dr. McKenzie, if you could start us out and just give us a brief overview of clinical trials so the audience, we're all on the same page throughout our discussion today.
Sure. I feel equally as unequipped to be at this esteemed panel here, but if you all are anything like I was as an undergrad, I didn't know anything about clinical research. We did not have, I went to a small liberal arts, religiously affiliated college in Georgia. You'll hear my accent come out eventually. And we did not have like a connection to a hospital system or a robust like clinical research program. So I didn't even know what clinical trials or clinical research was, even through graduate school. And I heard some of my graduate school buddies saying they were doing some translational work, and I was like, translational, what does that mean? Like you're translating something from a language to another? No, this was like taking a molecule that they were working on in a laboratory and trying to make it into a medicine in the clinic. And they were doing that through clinical trials. And so that was my first sort of introduction to what a clinical trial was. So maybe just level set with everybody. Every medicine that you've ever taken, whether it be an antibiotic or anything else, started as a clinical trial. That's how it started its journey to become something that you could go and take and get prescribed by your doctor. But before that, every one of those medicines started out in a laboratory somewhere with people toiling away with pipettes and all sorts of fun equipment that you guys probably get to play with here. And that journey of taking a molecule and making it a medicine is one of the most exciting ones for me. I think it's one of the most exciting ones in the world to talk about, because that's real like discovery, how you make human life better by toiling away in the laboratory and then eventually getting it into the clinic. But there's always this point in that journey where we call it the first in human experience. So the first time that that drug gets out of the laboratory, out of the animal models that we work in, and into a human being. Those are called first in human clinical trials. And these are where we have some of the bravest patients and people in the world who look their doctor in the face and say, yeah, I'm willing to do that. I'm willing to be the first human on planet Earth to take this medicine. It's an unbelievable thing. And we've got a whole network of these first in human phase 1 drug development programs. But that's the first step in a clinical trial and in the journey of a molecule becoming a medicine. And in those stages, really what you're doing is just trying to make sure that that molecule is safe, that it doesn't hurt patients when you give them, or you document all the side effects that might be happening, and you try to figure out what the right dose is for the patients to take that's not going to be crazy toxic for them. And then, once you figure that out in a very small group of patients, small number of patients, you expand that out into another phase of clinical trials, phase 2 or phase 3, where your endpoints don't become, is this super safe and is it not going to hurt people, but is it going to be effective? Is it actually doing the things that we hope it's going to do? Is it shrinking the cancers? Is it keeping them from growing? Those types of things. And then eventually, if you get all that data and amass all that data, you can submit that to the regulatory bodies for approval, and then it can become a new medicine. And that is what we do, at least I'll speak for myself here, but I know all of us participate in this. That's what we do every day, is come in and try to figure out how we develop new molecules, and how we can make that process better, how we can get more access to more patients to be involved in this discovery journey, because really, truly, that's where new medicines are being made. And as a patient, I know that I would want to have access to the newest and best medicines that are out there. And so I'm a big advocate in trying to get more people access to more clinical trials, because that's where all the best medicine is. So that's 3 minutes on what a clinical trial is and what that kind of drug development means. It's getting those molecules that we toil and work on in the laboratory into medicines that we can actually give to patients at some point.
Thank you so much for that wonderful explanation. I'm excited to turn back to the patient aspect later. I love that you touched on the magnitude of what it means for these patients to be the first in human, being willing to do that. But I'd love to start off broadly. So from all of your unique perspectives, what are the top challenges in drug development in 2026 that we're facing today?
Oh, an easy question. I'm going to turn to the ASCO CE. So I think, let me start with the exciting aspect. I want to kind of riff off of what you just heard, which is this is a time of incredible excitement and hope for patients. You heard that Terry was given trastuzumab or Herceptin, and that saved her life. And she's been living with incurable breast cancer now for over 20 years, and living, not dying. Since that time, since that drug was approved, we've seen the FDA approval of 7 additional drugs that target what's wrong with her cancer, that's driving her cancer. That's what Julie was talking to her about, is we've got to wait until we have another tool in the back pocket if your disease becomes resistant to this therapy. And thank heavens it hasn't become resistant, but all these tools have accumulated in that time. I just wrote a review article and just reviewing the advances in breast cancer in the last 6 years, and it is phenomenal. There's been 13 FDA-approved drugs just for breast cancer, and this is happening across all tumor histologies and not just for cancer. So I think there's a lot of excitement because the pace of discovery and the way that we're able to harness information now using artificial intelligence, et cetera, is becoming super, super exciting. There are challenges now with funding. I think you can't miss the news. We are seeing changes in the way that research funding is happening. It's making us have to turn and be more innovative in working with private foundations, the way that Julie was really innovative in working with NGOs to get funding to move these initiatives forward outside of the United States in these resource-restricted areas. We're going to have to become more creative, and I think we're going to be looking to you. Many of you are going to have to be thinking creatively in how to make this a top priority, but not just at the governmental level. We have so many untapped resources. We have so much funding that's outside of government now, and technology, harnessing partnerships with industry, pharmaceutical and biotechnology. So I think there are a lot of obstacles, and I think many of you are aware of it because we get inundated by social media and the media in general about the challenges that face us in science and technology. But I think that it shouldn't sway you from going into the area of research, because I think there's a lot of hope, and what we need is innovative thinkers.
Thank you so much. I'd love Dr. Murphy, Dr. Ashuri, if you had anything to add.
Let's see. Oh, this one works. Okay. I was just going to echo and say, I think drug discovery is happening now so rapidly. So many people are doing really incredible work in the lab and finding, new targets, new therapies, and it's almost, the pace is almost outpacing now what we're able to do on the clinical trial side, and some of that is restricted by funding, but also patient numbers and things like that, and so it's having to now really take us, looking and, which have the most promise for really revolutionizing therapy, and so that's kind of the difficulty too, in trying to figure out, like, not every drug is going to make it to a clinical trial, and most of those don't even make it, to be a medication that we can even prescribe. And so there's all of these sort of time points that we have to really evaluate and figure out which drugs to invest in.
Yeah, again, as a person on the panel who's not in the lab and doing this kind of research on a daily basis, the thing I see is we have so much information out there. We have so many resources, but we're not harnessing it in the right way. It's not, I think this new generation coming out should be able to figure that equation out. With all this information we have, how are we going to harness it? How are we going to get it into our patients? Are we going to use patient advocates like Terry on research boards to help us decide what makes sense for patients, what makes sense for the community? And I think that's the way we're going to be able to push it over the hump.
Thank you so much for sharing. Dr. McKenzie, did you have insight?
I don't want to harp on the problems that we have in this space. I want to talk more about the opportunities, but just maybe by show of hands for the folks in the audience, has anyone ever heard, and this is a perception question, have you heard that clinical trial is the last-ditch effort for a patient with cancer? Has anyone ever heard that phrase before? Yeah, I mean, look around. It's crazy. Like, that's the perception. I think part of the problem with clinical research today is that there is this perception that clinical trials are reserved for patients who've run out of options, and it's the last thing that they have. And I would love for this room to be a starting point of changing that perception, at least here in the communities that you affect, and that's not the case. A lot of these molecules and new medicines are really, really good, and they are being compared against what is the standard of care in a lot of times for treating that cancer. And so you're going to get great care on a clinical trial, even if you're doing it as the first therapy that you ever get as a cancer patient. And so I think I'd love to, and if you catch me later, I'd love to talk to folks about changing that perception around participating in clinical trials and what that means, and how you all, as the sort of next generation of scientists and researchers, can help push that message forward, because that perception issue is a real one that's pervasive.
Yeah, I just want to add to that. I think it's really important to recognize that clinical trials are appropriate even for early stage disease, untreated metastatic disease, that the regulations around the kinds of trials we can do ensure that patients are being given at least the standard of care or a therapy that's already met the level of proof, level of evidence to show that it's promising enough to be in those settings. But it is sobering. fewer than 5% of patients go on a clinical trial. That's really, really low. And so changing that perception is, I think, a huge important factor in changing the way that we can do clinical research.
I think that's so powerful to bring up, and I'd love to get your guys' perspectives as physicians. How do you approach those conversations with your patients when you suggest a clinical trial? I mean, how do people normally respond? And also, if you could share with us, how do you choose the patients that you think should receive the standard of care therapy versus putting them on these clinical trials? I'd love to hear, how you manage those patients.
Well, I hate to ping you, Shay, but you're overly humble, and you do this every day, so.
Well, again, the people here who know me, I'm pretty a simple guy, so I think it's simple. I think it comes down to the doctor-patient relationship. And if you have an oncologist who you trust, their judgment, like the story you just heard, and they have a treatment that just came out of the lab that they think is probably going to be more beneficial to you than the standard treatments, then it takes time and discussion with the patient and informed, I don't want to use the word consent, but essentially informed decision making to say, all right, this is the right choice for me. This clinical trial is the right choice for me, as opposed to the standard of care that I could get whenever I want to get it. And that's a difficult discussion, but it's one that should be had every time you see a patient with either a new cancer or something that's changed requiring a new treatment. I think most oncologists do a good job with that. When you connect it to a research institute like Sarah Cannon or UCLA or the Hutch, that makes things, City of Hope, that makes things a lot easier because you're constantly on the edge of hearing this information. Like the example I give is back when Dr. Hurvitz was at UCLA, we have an annual research meeting where all the clinical oncologists and the researchers get together in Arrowhead, and we kind of go over all the information for the upcoming year. And I remember one of our colleagues, a Dr. Rich Finn, who had nothing to do with breast cancer in any of his research, got up there and started talking about this molecule that's going to be groundbreaking for breast cancer. And he wanted to start a phase 1 trial in the community. And I'm sitting back there saying to a couple of my colleagues, what is Rich doing talking about this molecule? That's not his area. Lo and behold, this became a groundbreaking therapy. The CDK inhibitors that you probably see commercials for all the time, like Ibrance, Kisqali, Verzenio, groundbreaking treatments that we're using every day now in all stages of breast cancer. So it's that combination, and it's the time that the oncologist spends with their patient to see if this is the right choice for that treatment.
Thank you so much. Dr. Murphy, I'd love if you could give us a pediatric perspective.
Yeah. So I have the added complication, right, of we have the patients who don't always understand because they're young, and then the parents who, if any of you are parents, it's an extra, form of protection to want to make sure they're doing the right thing for their children. I think I'll just echo what Andy said in terms of how we approach it, especially in pediatrics, is our current standard of care has only happened because patients participated in clinical trials before them, and while pediatric cancer is still very rare, thank goodness, but because of that, we've had to really pull together institutions. Almost nothing in pediatrics happens at a single institution, and so much of pediatric cancer treatments are tested or done on clinical trials in large group efforts, consortia that everyone kind of bands behind to get these patients enrolled in trials and really get the patient number enrollments to really learn from the patients that are testing these new therapies. And so I think the mindset in pediatric oncology is a little bit different because almost all patients go on a clinical trial. It's it's kind of our effort to really learn from every single patient because it is so rare. And so, we approach that, and we also try to debunk the myth that, that clinical trials are because we don't know what we're doing or it's a last-ditch effort, and really, teach patients that this is just for us to kind of learn as you're getting this medication, how you're feeling while you're on it. So, and like Sarah said, we also really emphasize that we only are testing these medications that we think might actually improve outcomes or not be any worse. Obviously, we've been proved wrong in the past, but we're only testing medications on clinical trials that have really good preclinical data. So in the mouse models or animal models that we've tested on or in cell lines, we know that the outcomes look really good, that cancer is responsive. And so we have our standard of care, and we have this new medication that we think maybe will only improve survival rates. So it's sitting down with patients and really talking through these things.
Excellent, thank you. Dr. Hurvitz, did you have anything to add with those?
No, I think they covered it perfectly.
Amazing, thank you so much. And I think Dr. Murphy, you brought up really well that you need to be careful what clinical trials you do bring into clinic, into the network. So I'd love if I could just get your perspective also, Dr. McKenzie as well. How do you choose which trials to bring into your clinics and network? If you could just share with the audience a little bit more what that discernment looks like on your end.
Yeah, that's a complicated question. But I think on the pediatric side, we have all these consortium and everybody kind of gathering together to determine what the next clinical trials are going to be. What's really worth our time and investing in. And then, we're always really looking at that preclinical data and the underlying biology of the cancer and the medications that we're testing. It has to be worth it. It takes time to run a clinical trial. Julie showed us how long it took for her to get that publication out from the phase 3 trial that she did. And so, it takes time, it takes patience, and we really have to just make sure that we're testing the medications that we really think have the most promise. And I think that's kind of probably what all of us do regularly is really, it's challenging to kind of figure out what's worth investing in. But if there's really good preclinical data, it's really hard to ignore. That's what really gets us all excited.
Yeah, and I might answer this question with through a different lens, thinking about if I'm sitting in, how many biology majors, chemistry majors? Where are my chemistry majors at? I see you in the back there. I see you. Thinking about this is like what could I do because I got a chemistry major. I also got a biology major, but I don't talk about that one as much as I talk about the chemistry. In that, what would sitting in your spot, how could I think about what I could do with these degrees? And one of the ways that we determine what studies we take into our network, which we serve, we got a lot of mouths to feed. We've got 20 different oncology practices across the country, 200 different locations of research, 1,500 doctors that all want to do research, a lot of mouths to feed. So that means we got a lot of clinical trials that we have to try to get out across that space. And we've hired a team of scientists, basic scientists. These are folks who got degrees in chemistry, biology, biochemistry, went on to get PhDs in human genetics or molecular biology or cell biology. And what they do is understand this disease landscape, for lung cancer, for instance, really, really well. So they know the ins and outs of all of the preclinical data, the cell models and the mouse models, what's working, what's not. And they're really tuned into the world of the biotech and pharma world. So what's Pfizer got in their pipeline? What does GSK or Merck or whoever else have in their pipelines? And in this world of all these mouths we've got to feed, where do we have gaps that company might have something in their pipeline that we can fill? Again, as I said at the beginning, to give as many patients the opportunity to participate in trials. That's the lens that we always look through. So we've also got population health folks who are looking at what's the incidence of lung cancer in West Virginia, and how many of those small cell lung cancers do we see up in Oregon? And that way we can make really evidence-based decisions about where we put certain clinical trials. Doomsday scenario is you open a trial for small cell lung cancer in a place where there aren't any small cell lung cancer patients, right? Because that's not going to help anybody. What you want to do is make sure you put that at the place where you see those patients who will have the opportunity to benefit from participating in those. So there's a lot of fancy footwork that goes behind the scenes from a data science and technology point of view, but at the end of the day, it's scientists like you all are and are going to be who are helping us make sense of the landscape of drug development and where we can be super strategic about putting a new medicine in our, at least Sarah Cannon, the network across the country. So it's a lot of different things that go into it, but led by physicians, supported by scientists, and a ton of technology and data science in the background to help make that work.
Yeah, I think what you're hearing is that we want the science to be accessible by as many patients as possible, but we also want the questions being addressed by the trial to be impactful scientifically and to help the field progress. And so part of what also goes into thinking when we're assessing whether to do a trial or when we're developing a trial as an investigator-initiated study or a study that's part of a cooperative group is what is the critical question to ask and answer in order to move the field forward. And to come up with those questions and interrogate that a little bit further, we partner with our patient advocacy groups because they tell us what's important to them. We partner with our lab-based scientists and with our clinical scientists to come up with that. And one key component, it's not just about enrolling patients on the trial and then waiting and getting an answer and getting a publication and seeing the drug get FDA approved, but translational research, that term that was brought up, is not just about from the bench to the bedside, to the clinic, but it's from the bedside back to the bench. Meaning, does this clinical trial incorporate gathering information from the participants who were enrolled, be it through questionnaires about how their quality of life was affected, be it through blood testing or collecting tumor samples to go back to the researcher who then looks at what happened to that cancer or to that patient when they receive the therapy. How is that therapy actually impacting the cancer or normal cells? Those are really important outputs of clinical research that you may miss. It's not just about getting a drug approved.
Amazing. Thank you so much. I think that's such a great window into everything that goes on, behind the scenes. And with that, I'd love to hear a little bit about what emerging therapies are you all excited about? Of course, they're coming from the synergy right between the lab and the clinic. What emerging therapies are you most excited for on the horizon? And if you could share in the audience why they're going to be so impactful for our patients.
I guess I'll take that one. So in the clinic, I think obviously we want drugs that are going to be the least toxic to our patients and the most efficacious at the same time, right? You want a little bit of everything. So there's been so much development in the last, I would say, 5-6 years with completely new mechanisms. One of which I think we use a lot in our clinic is antibody drug conjugates, something that Dr. Hurvitz again is very involved with. And these are drugs that kind of use the monoclonal antibodies that you guys saw in the slide set, but they attach an actual chemotherapy drug to it to kind of deliver the drug to where it's supposed to go, to the cells that it's supposed to go. And I think it's fascinating. It's kind of like a smart bomb, essentially, that's going exactly where it's supposed to go. And we've been learning a lot about, the first group that came out, we had a lot of toxicities on the clinical trials. That helped us send it back to the researchers and say, we can't do this. They came up with new guidelines that we're implementing in our practice now that the drugs are approved. So I think that's been a really good story the last few years. And obviously, I'll kick it back to you guys, but the immunotherapy drugs, that's what everybody keeps talking about.
Yeah, I can probably touch on immunotherapy. I would say immunotherapy has completely revolutionized pediatric leukemia in the last decade. I think the biggest success story in pediatric leukemia is CAR T-cell therapies. So I don't know if any of you have learned about those yet. But basically, we're harnessing the patient's own immune system to then fight their cancer. Instead of giving chemotherapy drugs, which are mostly targeted at any rapidly dividing cell, which oftentimes is the cancer cell, but other healthy cells, take a hit with that. Here, we can instead use the patient's own immune system to fight the cancer. And so with CAR T-cell therapies, we take T cells out of a patient's body, so part of the immune system, the T cell white blood cell, And then we, in the lab, they're able to, transduce them with a new receptor that specifically can then target a marker on the surface of the cancer cell, and then you give those cells back to the patient, and their own T cells can go and kill the cancer. Has resulted in really phenomenal remission rates. And now we have CAR T cell therapies for all kinds of cancers, lymphoma, multiple myeloma, a lot of all kinds of solid tumor work being done as well. And so that's, I think, really thinking outside the box. And then, in addition to kind of cell therapies, we also have sort of bispecific antibodies and things now where, the antibody can then bring an immune cell into communication with the cancer cell and sort of do some direct killing by that communication and pathways that the cells communicate. And so it's really remarkable how much we're now really looking at the immune system and how can we harness what we already have to kill cancer.
I'll just add a couple of things. One is we should have had a collective gasp in the room when she said that we take a patient's own T cells out, take them to a laboratory, engineer a new thing on it, and then put them back into a patient. That's crazy. That happens, though. That's one of the mechanisms that we use to treat cancer patients. Like, that's unbelievable that we can do that. And I think is one of the more exciting things that we're doing in oncology today. My space is a little bit different than that. Yes, we play in the immunotherapy, and we also play in some of the other chemotherapies and antibody-drug conjugates, but where we focus a lot is in the genomics and genetics of oncology. It's long been theorized that oncology is a disease of the genome or a disease of the genetics of the cancer. And we've just got to have more smart people figuring out what are the actual mutations that cause that initiation of and progression of cancer. We've done really good work in some spaces, and we've developed what we call these targeted therapies. So this is when a cancer cell has one of these mutations that it expresses in the DNA, and then we're able to build, like I do anything in this, but our pharma partners are the ones who actually build these really exquisite molecules that target those specific mutations. And so kind of like the smart bomb idea with antibody-drug conjugates, these drugs are only meant to interact with the cancer cells that have those mutations and spare the rest of the normal cells that are around. And so these targeted therapies came on, even in the blood cancer space many, many years ago. And we've continued to sort of build our armamentarium, a fancy word for just drugs we have on the shelf, that we can throw at these tumors as we learn more about the genetics and genomics of them. So I'm still very excited, even though it's kind of old hat now, targeted therapies are. I'm still excited about the possibility that these will have as we continue to learn more about different types of tumors, what types of mutations they express, and then how we can target those with very specific targeted therapies, as we call them. So I'm still very excited about that, even though I know it's not as in vogue as it used to be maybe 10 years ago.
Oh, I think it's hugely in vogue. It's really we have some amazing data in breast cancer for these small molecules that go after it. So you've heard about these bulky antibodies that are used to link to chemo, and it's a whole Trojan horse technology to go after the cancer. You've heard about harnessing the immune system to go after cancer specifically, and small molecules, which are typically pills you take to specifically, they're chemicals, so for you chemists, it took chemists to figure out how to just specifically go after what's wrong in the cancer cell. So these are all really highly targeted therapies, and I agree these are the most exciting things in oncology. I am equally excited about what's called de-escalation or right-sizing therapy. And I think we're seeing a revolution in the way we treat cancer across the different cancer types, where we are moving from, and you spoke about this a little bit, away from killing indiscriminately with cytotoxic chemotherapy and giving as much as a patient can handle, to an era where we see what is the Goldilocks, right? What is the just right amount to get the patient cured or to give them the longest survival possible, but without making them really, really sick and affecting normal cells. And I think we're seeing that across different cancer types now.
Thank you so much. It's so wonderful to think about and consider. I'd love to dive in a little bit more to personalized medicine now. A lot of these therapies are available because we've just transformed, revolutionized, right, our power of genetic analyses, being able to study patients specific their genome. I'd love if we could just discuss that. How have you seen that revolutionize medicine? What role do you think that plays in personalized medicine? I think we've discussed some of those ideas, but if you have any additional thoughts to share.
Well, maybe I'll start off. I think that it is really crazy how much we've seen cancer change and outcomes change. I'm not a lung cancer specialist, but I can tell you that when I was in training in the late 90s and early 2000s, we would diagnose patients with lung cancer, and they would die within a year, typically, with metastatic lung cancer. And now we are genetically looking at the tumor, and a large proportion of them have genetic alterations that are targetable by pills or monoclonal antibodies or immune therapy, and it has revolutionized it. Now we're seeing patients live years with metastatic lung cancer, to the point where we're actually building survivorship clinics for patients, which was something that we wouldn't have ever put the resources in. Breast cancer, similarly, we look at things like whether the tumor has hormone receptors, whether the gene for the hormone receptor is mutated, which can happen in about 40% of treated breast cancers, whether there's a HER2 amplification or expression of HER2, and then we look at all the other things, BRCA mutations, PI3 kinase mutations, and so we are sort of crafting a personalized therapy for patients who are diagnosed with different cancers, and it's enabling patients to live much longer and better.
Yeah, I'll just echo that. I think, almost on every patient now that we get, we're immediately sending genetic testing on their cancer, and that information that we get back, will tell us if there's targeted therapies and stuff that we can go after, but it also gives us a really good idea now on prognosis, right? And that helps us also, to echo Sarah's point, which patients need intensified therapy, because we know that cancers with that genetic mutation, are really hard to kill with chemotherapy alone or some of our other approaches. And then which patients can we actually de-intensify therapy, like you said, because why blast them with so much chemo if actually their cancer is really sensitive to chemotherapy, and we can maybe give less. And so that's allowing us also not just to approach it from a targeted therapy standpoint, but how intensive therapy needs to be, and allows us to sort of now we risk stratify patients, based on genetic markers and things that we find in their leukemias, to really figure out, how intense, how can we de-intensify, and give them, some ideas on prognosis too. So all of this, research over time has really given us patient data that we can now go back to and say, patients with this type of genetic mutation experience, these sorts of outcomes. So that helps, I think, for a lot of patients too.
Yeah, and I might say, as was discussed earlier, the evolution of this medicine has been just unbelievable. Truly, unbelievable how fast this stuff has happened. I mean, it wasn't but 20 years ago where it was you were diagnosed with lung cancer, breast cancer, right? And they were treated relatively similarly. But now, I'll pick on lung cancer again. You've got lung cancer that can be split into small cell versus non-small cell, just based on the histology, what the cells look like. But then you can take the non-small cell lung cancers and you can break them down into, is it an ALK positive, EGFR positive? These are all mutations that you might find. ALK positive, EGFR positive, BRAF positive, ROS1 positive, NTRK positive. So now, instead of treating lung cancer, you're treating ROS1 positive lung cancer, and you treat it incredibly different than you would if it was ROS1 negative. And so the only way that we know about those things is because, as you saw in some of the slides from Dr. Gralow, is you've got incredibly smart, driven people saying, why does that cancer cell do that? And why is that different than that one in that dish? And they're figuring out these sort of basic mechanisms for how these cells work. And then there's that discovery day of oh my gosh, this one has a mutation in EGFR. And oh my gosh, if we put this drug on that, it responds completely differently than if we did this other combination of things. And so again, my bend here is, for those of you who maybe not be going on the medicine track, there's still a lot of opportunity for you to participate in this whole world of drug development. And part of that is in that understanding of the basic sciences, what's happening at the cellular, but not even that, the protein, but not even that, the genetic, not even that, the epigenetic level, as you understand how these cells and biology work. So that's my view on the personalized medicine front. I think we got a lot of work to do, and we're not done yet.
Yeah, I mean, I'll just tag on to that. It's all that hard work that happens by the scientists in the lab doing the research that then we get to sit in front of a patient in the clinic and say, hey, yes, unfortunately, you do have stage 4 lung cancer, but luckily you have an EGFR mutation, and instead of going down the chemo path, I could put you on a pill, and you're going to be fine 5 years from now. Which is something we actually say to the patients nowadays. So, I mean, it's a huge difference from same time I was training as Dr. Hurvitz, you know, the lung cancer trial that comes out showing 4 new drugs, 4 different regimens, and the same exact curve. You know, all the drugs we gave back then worked the same because it was a one-size-fits-all theory. We've come a very long way in 20 years. We still have a lot to do, but we've come a very long way, and it's because of this collaboration between the scientists, patients, and clinicians. I think that's where we get our success.
It's an exciting time to be in oncology. I think that's what you're probably getting from all of this. It's moving quickly, and it's changing the field completely.
Yeah, it's incredible that Dr. Gralow, Dr. Shuri, I think you two are younger, but that we went into oncology because they were dark days back then. But now we're actually taking a blood sample, and we can measure tumor DNA in a patient's blood sample and test for those genes without even doing a biopsy in the tumor, and know how to treat that cancer just based on that circulating tumor DNA. So the technology is just going so fast, and it's a really exciting and hopeful time to enter a career in this area.
I think that's such a hopeful note to consider and just to keep in mind, right, as students looking into these fields in the future. I'd love to hear that. It's so interesting, you know, how maybe your outlooks have changed on just the field of oncology, or even just your career, right, as, you know, getting to treat patients and to interact with them. How have all these innovations really, I think, transformed your career for you, and how you're able to just deal with your day-to-day tasks?
So I went into oncology. I came from a family that had 0 people in science. They were liberal arts. My dad was a probation officer, had artists in the family. And so I was the black sheep, putting my foot in the water of science. Very reticently, took gap years like Julie did after undergrad, a couple years, toyed with going into law. Yes, law. Was a paralegal for 2 years and finally decided to go to medicine. And what ultimately drew me to oncology was the patient relationship. I just loved sort of that instant, intimate connection with the patient. And learning to meet them where they were at. It wasn't a visit, not to say anything about other specialties, but you just get down to the core. It's kind of life and death at that time, and that drew me in. I think probably 5 years in, I would have burnt out, because I too, Julie, saw patients outside of the clinic and met them at things, went to funerals. I really connected with them, and that takes a toll on one emotionally. Without the science as a counterbalance and the research, that's what allowed me to move and continue, was that hope that we can find a better way. And having been able to realize and see that in my career has been incredibly special.
Yeah, well, this is a good question. I'm going to come at it a little bit negative. Hang in there with me. Because the science has advanced at such a breakneck pace. You've heard that from all of us. My gosh, the rate of discovery is just unbelievable. but the rate at which we're approving new medicines is not going that fast. And so I look at it both as like the hope of all of these amazing scientists doing incredible work, creating brand new drugs, and we're tying that to, and Deanna and I talk about this a lot, a chassis of old school drug development in America. And that's just because it's the same old phrase you've probably heard, that's just the way that we do it. And we're at a point in time now where I think there's too much at stake from a scientific point of view, but also just the patients who need us to think about it differently. We can't have the this is just the way that we do it attitude. And so I'm gonna say the four-letter word here that's just two letters, AI, that is one of the tools that we're using now to help speed up or augment the way that we think about developing drugs, which is great, but again, we're tying it to that chassis of the same old way that we've always done things. I think it's going to have to be folks like, of course, my colleagues here on stage, but you all, the next generation of thinkers who say, yeah, that is the way you do it, but why do you do it that way? That's kind of silly. And then give us the roadmap for how we build the next way to actually develop drugs in a quicker, safer, cheaper way to make more new therapies available to more and more patients who need them. So, Madison, I think to answer your question, like, I've seen that arc of like, oh my gosh, I got into oncology right when things were just like taking off like a rocket ship. And it's been so exciting to be a part of, both in the laboratory and now in my role adjacent to the clinic. But then I see just this like despair of like so many things taking so long to get through that process and actually become new medicines for patients. And so not to discourage, but to hopefully inspire that, you know, we need new brains and new thoughts about that.
Yeah, we need innovators in the field for sure. I mean, I think for me, why I got into this field was I initially sort of started in research here at Pepperdine, actually. And I think it really takes someone who's curious, and who's constantly asking those questions, like, how can we make this better? And so if you are, research-minded, it's actually a perfect field, because for me it was, even when I was in the lab, I was like, but why do I care about this protein? Well, I care because, this patient may have overexpression of it. It actually translates back to the human level and why some of that matters. And so I think, for me, I also entered into the field when it was, really taking off. And it was, it was and is such an exciting thing to be a part of. And to be able to tell patients, like, look at how far we've come. Patients used to just die of this. There was no hope. And now, we're curing patients. And especially for me in pediatrics, I would say, it is sort of that immediate, intimate relationship you have with families. I really wanted to have a relationship with my patients, and other specialties I felt like I didn't necessarily get that as much, and it's almost like an immediate bond you form with those families, and they trust you, if you do it right. And I think that's really the key, is to build relationships. And in pediatrics, it's very rewarding, right? If I can walk along that journey with patients, and oftentimes it doesn't end the way we want it to, but the journey you've shared with them is still something that is appreciated, I think, all around. And then on the flip side, if we do get to cure patients, I'm attending high school graduations, college graduations for kids that would have died 10 years ago, and so there's nothing more rewarding than that, I would say. So that's why I'm in the field.
So, funny story, like Sarah, nobody in my family is in science or medicine, and I was an undergrad at SC, built a good relationship. I had to take Bio 101 freshman year. I somehow, in a huge class of, I think, 700-800 people, I became buddies with our professor, and we would hang out, and we would have lunch, and he just got me curious. So it started from that. And another funny story, my interview at USC Med School was actually Sarah's husband. And his first question to me was, why do you want to go into medicine? And I told him I really want to buy a Porsche. And his face turned white. He couldn't believe it. I'm like, I'm just joking. I wasn't, but I had to tell. Anyway.
Little did you know he
Yeah.
just bought a Porsche.
There are easier ways to get a Porsche.
But all that to say, I think it comes, again, I'm simple. It comes down to relationships. I was a political science major. I didn't think I was going to do this. I met one mentor. He, just through relationships and talking, got my curiosity going, led to med school. Didn't think I was going to go into oncology at all. Again, my curiosity got me hooked up with the right mentor again. She convinced me that, this is what I should do. And I don't regret it. It is hard. It's very hard. But again, the part that keeps me fascinated every day is that balance between what these smart researchers tell me and how I could apply it to the patient who's sitting in front of me who's looking for hope. And I think that's invaluable. I don't think there's anything else in the world that means as much to me.
Thank you so much. I think that really hits at the core of today. And with our last 2 minutes, if I could just have each of you share, what's the biggest piece of advice that you'd want to share with all of our students here in the audience looking to go into medicine and science in the coming decade?
When doors close or are slammed in your face, and they will be, look for the next door in the next room or the window. And failure is okay, and often will lead you to a better opportunity.
Yeah, you stole mine, because that last piece is the best advice that I ever got was I would take results from an experiment into my boss's office in graduate school, and I would say, Alan, it didn't work. And he'd look me in the face and he would say, every experiment works. You just got to know what it's telling you. And I think that's true in life and in the sciences. Just because it didn't tell you what you hoped it would tell you, or you didn't get the result that you thought you wanted, there's something to learn from that experiment that you did, whether that's in the laboratory or in life. And that can propel you to be a lot more curious and figure out a whole lot more stuff than just saying, oh man, it didn't work. And so I would say that perseverance and framing the questions of when you get the bad news or not the right thing that worked out, that framing in your mind can take you a long way. And I would encourage you all to do that.
I think it's hard. We all have sort of similar, you're all stealing ours. I think the biggest thing is, stay curious. If this is a field that you're interested in, there are so many different ways to get into the field too. You don't have to be an oncologist, but like Indy was saying, you can be on the research side of things, work for the pharma companies, be an advocate. There's so many ways to get involved, but as the field is moving forward, it's moving quickly, and it's really all of us asking questions, right? Like, why can't we do this better? What can we do to make patients' quality of life better? All of those questions, every single one matters, and it takes somebody who's gonna dedicate to answering that question. And that all comes from, the key curiosity. So stay curious, and really lean on good mentors. I would say that mentorship is really, I think all of us have expressed today that finding really good mentors who are going to kind of take you under their wing and lead you to really interesting projects, but also teach you about how to be a physician, but also a human on the side, is all of that is key to being a great oncologist or person in this field. So.
I would definitely say perseverance, but at the same time, listen to your gut. I think your gut tells you a lot. That's why mine is so big. And number 3, which I think is very important, it helped me a lot, was ask for help. If you're confused about something, if you want to learn about something, ask for help. Maybe somebody will shut the door in your face, but there's somebody next door. You keep going. You just ask for help, and eventually there's people out there that'll help guide you.
Well, thank you so much for those wonderful words of wisdom. We're going to transition to our Q&A now. I'm going to invite Chair Smith back up to the stage, as well as Dr. Gralow. But could we please have a wonderful round of applause for our speakers? Thank you.
Okay, this is the super fun part. So first of all, you guys are fantastic. I'm so grateful. What an impact on our students and all that are here. So you guys know classes, so you've seen people leave and then come back and new people come in. So again, thank you for being here. Dr. Gralow, sorry I'm making you turn a little bit, but you're okay. All right, guys.
She's climbed Mount Kilimanjaro.
I know. Like, I am the biggest loser, literally the biggest loser. I've got to get with my career. Let's go. So, guys, we have a lot of nursing students here. And, wow, do nurses play such a vital role? At Sarah Cannon, we talk about that nurses are the glue to the whole deal. Skip Burris, who many of you know, Dr. Burris will say, you know, get a really good doctor, but a great nurse makes or breaks it. And so I want to talk about nursing and about the importance of nursing. Dr. Shuri, I'd like to start with you first. I know the answer from all of you because you can't make it, right, without them. But I would love for you individually to talk about the value of the nurse in your clinic, and maybe even particularly, you can take either angle, their role in clinical trials and in conversations with the parent, in the patients or the parents. So take it any way you want to, but let's let this be predominantly focused on nurses.
So in one word, invaluable. I think from my training, it was the chemo nurses in our infusion clinic who taught me how to administer chemo, taught me how to dose it, taught me how to listen to the patient. I remember their names. It was over 20 years ago, but I remember they were amazing. To working in a clinic closely with nurses, patients want to impress their doctor. I'm sure we all do it, right? We walk in the room, we say, oh, everything's fine. And then 5 minutes later, they're talking to my nurse and like, yeah, you know what? This hurts, that hurts, but I don't want to tell the doctor. I mean, the patients tell nurses a lot more than they'll tell their doctors. And again, that helps us a lot. And it's because of that trust and that compassion that nurses give to patients. So I think their clinical role is invaluable. In terms of research, one of the questions earlier on was, what are some of the impediments of putting patients on trials? I think having clinically savvy nurses help run patients on clinical trials would be one thing. For a clinician who's busy seeing multiple patients would be invaluable. I think that, some of our practices use that. We use nurses or even nurse practitioners to help some of our patients on clinical trials, and home run job when the patients are on those trials with those nurses.
Dr. Murphy.
Yeah, I'll echo that. I mean, I would say, the nurses are probably the most important healthcare people to the patients. I mean, they whether the patient's, admitted to the hospital and inpatient, that nurse is there, at their bedside all day, all night, and they're the ones that the patients end up, I would say, yeah, they get the most information from the patients, and that relationship, I think, is essential. And then, the relationship with the nurses and the physicians then is also, we're all looking to do, what's best for the patients. And it definitely, I mean, we rely so heavily on nursing. We could not do any of our jobs without them. I have so many good friends now that that were nurses who are mentors to me, and it's a great clinical relationship. And on the research side, nursing again is essential. Like, we cannot do clinical trials without really good clinical nurses, and so much of what we do, right, is right there at the bedside, and we're not always the ones giving the chemo or giving the treatments. The nurses are the ones doing that, and they're, invaluable. And I was also just going to say that, especially when we're testing like new medications in clinical trials, like the nurses also, none of us really have experience sometimes with these medications and the sort of side effects and things that we're going to see happen in the patients. And so having nurses who are really good, like clinically trained and can recognize sort of things in can be they're the first ones at the bedside, right, to treat the patient for anything they may be experiencing. So it's so great that there's so many nursing students here and that the College of Health Sciences is here.
And Dr. Murphy, do you see that do you see this conversation, particularly in pediatrics, just thinking about that lens, you're talking to the parents, and so do you see that nursing relationship really giving them the comfort? Dr. Shuri said, they might talk to the nurse more even than they might talk to you. Do you see that particularly in pediatrics?
For sure. I would say in pediatrics, we almost never wear our white coats, right? We're trying to not be intimidating to the patients. But the nurses are the ones, right, that really are forming the relationship. They sort of, there's play therapy, there's other stuff that happens, to try to get patients to take their meds, and that relationship is invaluable. And so, many of my pediatric patients will talk to their nurse and they don't talk to me about anything. And so I'm getting it from the parents, which is secondhand. It's not as great as what the nurses can get from patients. So absolutely, the nursing relationship is essential.
And Dr. McKenzie, knowing that your team is adjacent to the clinic, talk about what you see from a nursing perspective and maybe even the opportunities that you might see for nurses if they're, don't in clinical research where they don't necessarily choose to be bedside.
Yeah, my super quick answer is if I ever need something done, I go talk to the nurses, and they are the actual doers, movers, and shakers. I actually have on my team a handful of nurses that are no longer in the clinic, but they're doing things from a research point of view centrally for us, and what their job is called is central screening. And so they're actually looking at patients across the country because we've got a bunch of technology solutions that allow us to look at a patient in Eugene, Oregon, or Wichita, Kansas, or wherever else, to look at their medical record and see, does that patient actually qualify for this clinical trial that we have near their home? And if they do, they're the ones who reach out to the doctor and say, hey, Dr. Smith, you're seeing Mrs. Smith come in next Thursday, and she's an excellent candidate for this trial. They're building that relationship with those doctors through a totally different mechanism than the traditional type of in the clinic, in the practice relationship, and has been an amazingly successful thing for us to help get more patients on trials. So lots of opportunities, and again, they're the doers, the movers and shakers. When I need to find patients for a study, this, that, and the other, it's those nurses that I go to help. They are the people I go to for anything that I need to actually get done. And I hope that's not offensive to anybody.
No offense to the MDs.
Yeah, I would just echo what everyone has said and just add, nursing's not just, as you said, patient-facing, but often there are leadership positions. A lot of nurses end up leading clinical research organizations, taking leadership positions in pharmaceutical industry and biotechnology. I mean, the information and education that nursing gives you and is really phenomenal. And so a lot of nurses will do patient-facing work for a few years, but then really focus on research or administration. We have a lot of administrative leaders at my institution that are nurses. Also would include nurse practitioners and physician assistants in this sort of umbrella. And so the sky's the limit. There really are opportunities to be involved in research and administration at a very high level with a nursing degree.
And I would add, it is very clear that I could not have done the things I do, both in clinic, but outside of clinic, if I did not have an amazing team that I was working with that supported me and helped me. That includes nurses, our advanced practice providers, the nurse practitioners, physician's assistants, my scheduler in clinic, our medical assistants, the whole research team. I mean, we really did feel like we were a team. I made sure everybody celebrated all of the successes. And in my 30 years that I was in clinic, I only had 3 nurses during that time. They were very committed. They were breast specialized. You know, they talked to the patients more than I did. You know, I'd have a 20 or 30-minute appointment every couple months or whatever, but they would be the ones, and there were many questions that they might want not to ask me. And our chemo infusion nurses, which were a separate group of nurses, you're in there for a 2 or 3 hour infusion. Who do you talk to during that time? I mean, they got to know things. They would send messages back saying, hey, do you know this is going on in this patient's life? Whatever. It takes an amazing whole team to really deliver the best care. And so there is a role for everyone, but everybody should be able to celebrate all of the successes as well.
Healthcare is really a team.
I could not have done what I did.
Right, it's a team sport, isn't it? Staying on the nursing theme just for another moment or two, Dr. Hurvitz, when you have a new oncology nurse that comes into the clinic, what do you wish they knew? Now, they can't know everything, right, because they haven't. What would you say? So this specific question is, what is something that you wish every new nurse understood about caring for oncology patients? What would that one thing be? That's a hard one.
So I don't think it's about knowledge base, because I think I would assume you come in with a knowledge base that came from nursing school. I think it's sort of an intentional willingness to listen and learn, and to have humility and ask questions. That goes not just with nursing. I think for any of the medical students that work with us, and APP students or new physicians, we want to see sort of that humility and listening to the patient, being prepared for the patient you're going to see, and asking questions. And Shay said this earlier, asking questions, ask for help. Shay calls me sometimes about a patient. I call people in my group about patients. What should I do here? Have that humility to ask other people for their input and feedback. That was longer than one thing. I kind of went everywhere with it, but
I love it. It was perfect. Dr. Murphy.
That's exactly what I was going to say. I think asking questions, and we don't expect that, right? You're going to walk into the oncology clinic on day one and know everything that you might need to know. A lot of that comes with time and practice. And so what's really key is just to know that you can trust your nurse, right, to ask questions if there's something they're not sure about, to be able to, at the end of the day, we're all just trying to provide the best care for patients. And so I'd rather have a new nurse say, I've never done this before, can you walk me through it or help me, than to have a new nurse necessarily go into clinic and sort of pretend, and that, I think that ends up getting you into more trouble. And so, again, it's a team effort. I would never mind for someone to ask questions. We're all learning every single day, and so there's a lot to learn in oncology, but coming and being curious and asking questions about why we do things the way we do, that would be key.
Dr. Shuri, I know you have a busy clinic. What would you say?
Well, I think the knowledge, we assume you have it. If you went to Pepperdine Nursing School, you're going to have the knowledge. It's the other factors that I think we all test when we first meet a new nurse is, are they going to ask us questions, or are they just going to act like they know everything? That's a red flag. It's teamwork, right? Nurses are kind of my AI. So I need to be able to talk,
that's good.
and I need to get information, and they need to get information from me. So, I think that's what you need to bring is communication skills, data processing, so that you could communicate clearly with your coworkers and doctors.
Great. All right. Dr. Gralow, this was very specifically requested of you, this question. How will the U.S. departure from the World Health Organization affect your and others' work in global health with ASCO?
I was in Egypt a couple weeks ago, and I watched our flag being pulled down from the World Health Organization headquarters in Geneva and cried a little bit. But I will tell you that, so ASCO, our organization, has a memorandum of understanding with the World Health Organization, and I went to my colleagues there. It turns out that the head of cancer trained at the University of Washington, and then MD Anderson, Andre Albaue, and so I've known him since he was a resident, and I said, does this in any way, shape, or form impact our ASCO MOU with you, or any of the work that that we can help you with around the world? He said, absolutely not. The memorandum of understanding is with ASCO, not with the United States of America. So, you know, I spend a lot of time in Geneva for a lot of reasons, which is where the WHO is headquartered. Rest of world can separate us from the current administration, and they are taking their partners and their partnerships and their relationships that they have with separate U.S. groups and not treating it like the U.S. government. So it makes it harder, and there's a lot of money that's now not there, and the WHO has had to majorly cut their staff, and like there's a bunch of issues with us withdrawing, and it's going to hurt us as Americans too. There's no question with respect to disease monitoring and things like that. But we are continuing our work just as strongly as ever from the American Society of Clinical Oncology with the WHO.
Great. Okay, so this is a tricky one because it depends on where you sit in the boat, on the bus, whatever is your mode of transportation. Does this panel think that cancer will be a curable disease in your lifetime? Again, remember, some of us have longer timelines than others. So, Dr. McKenzie, I'm starting with you.
My thought on this is no, but not for the reasons that you think I'm saying no for, like it's an impossible thing to cure. I think no, because when you say, is cancer going to be cured, you're lumping all of cancer into one giant thing. And as we talked about earlier, even in lung cancer, there's like 50 different types of lung cancer. And so I think what we will see in my lifetime, I think everybody's lifetime here,
Mine too, Andy.
Is that for certain types of cancers, we will see huge progress made into turning them into first manageable diseases, even in the advanced stage of cancer. And then eventually, as we get better at detecting them earlier, with new advances in things like multi-cancer early detection and other cool technologies that we can talk about later, I think we're going to get to a place where cancer by cancer, we're going to see cure rates rise. But I don't think if you're going to ask me like in 2030, is there going to be a magic pill that cures all of cancer? I don't think that's the way that it's going to happen. But it's more of as the science evolves and we learn about each individual tumor type, we will get better at treating those cancers, turn them into manageable diseases, and ultimately, I think, drive towards step-by-step increasing our cure rates across the cancer spectrum.
Dr. Hurvitz, maybe for you, a particular focus on breast cancer.
Yeah, it was a perfect answer, Dr. McKenzie, because it isn't one disease. It's many, many diseases. And so within breast cancer, I think we've already seen immense progress. You heard Terry's story of HER2-positive metastatic breast cancer, which back in 1998, when the first study, randomized study of HER2-positive metastatic breast cancer was reported, the overall survival, about half of patients would have died by about a year or so. And now we see that that's gone up to beyond 5 years, and it's not uncommon. I have multiple Terrys in my own clinic who've been living with metastatic breast cancer beyond 10, 15 years and have seen their milestones and have gotten to their goals in life and are living out their life because of that. But not all subtypes are seeing that sort of progress. And so do I think in the next 20 years we're going to see progress? Yes. In breast cancer for sure. I think we're unlocking a lot of the problems that are leading to aggressive behavior in the subtypes that haven't had the sort of success that HER2 positive has.
Dr. Shuri.
Yeah, I think cure has always been a hard word for us to use. although I'm starting to change now. I do think we are curing some cancers, things that we weren't 20, 30 years ago, right? So I do think the field has definitely moved. Big picture, we have a long way to go. Yeah, so it's not going to be a one-size-fits-all pill that someone's going to take and they're going to be free of cancer. But I think the way drug development is going, the way, detection is going with what we talked about a little bit earlier with ctDNA testing and managing that on how to treat patients and determine whether someone is cured or is not cured. I think there's so much on the horizon that I think in the next few years there will be dramatic improvements. But no, I don't think it's going to be a one cure fits all type of thing.
Dr. Gralow.
So I would take we're curing some cancers and say we're curing a lot of cancers. There is a huge difference in the United States and globally between the incidence, the number of cancers that are diagnosed, and the mortality, the number of deaths. Huge. So we are curing a lot of cancers. Our vision at ASCO, I really like. A world where cancer is either prevented or cured and every survivor is healthy. That's where we want to be. That is our vision. And so you could turn that question, are we going to see a cure for cancer in a lifetime? And cancer is probably at this point 10,000 different diseases if you take where it originated and what the genes are and everything. And so that's what we're hearing. But, we can likely eliminate cervical cancer. So can we eliminate cancer in our lifetime is another question, like eliminating polio. Cervical cancer with the vaccine and early detection before the point at which it's actually a cancer, you can eliminate cancer. And from some of the HPV vaccination work coming out of countries that really invested and got a good uptake of elimination, they haven't seen a new cervical cancer diagnosis in the cohort that got their vaccines in a few years now. So there are cancers, but that's a virus, right? The WHO estimates that at least 30% of cancers are caused by lifestyle factors. So a modifiable factor, that's tobacco, alcohol, excess weight, things that we actually could maybe do some elimination of cancer as well. But still, even people who do everything right and get all of their vaccines and don't smoke and don't drink and exercise and have a good body weight get cancer. So that's where you're asking. They're still going to get cancer because we don't know what causes it. We're not going to be able to eliminate that, but hopefully we'll get the cure and they'll live out a healthy life.
Dr. Murphy, how would you see this in the pediatric space?
Yeah, I think it's hard because, like you were saying, so much of cancer in the adult population is attributed to lifestyle factors, but we don't see that as much in pediatrics, right? If a 3-year-old walks into your clinic with a new diagnosis of any cancer, you can't be like, well, you smoked for 20 years. We don't know why these kids are getting cancers. And it's especially interesting because, we're doing so much work now from the genomic side trying to figure out how much of this is inherited, and we are finding some cancer predisposition syndromes and things that you can inherit or pass on to your kids. But so much of it we don't know, and because of that makes it really hard, right, to look for cures. But I just would like to echo what everybody has said, and that we've made significant progress, and there are a lot of cancers that we are curing, or screening and preventing. But even we may not be able to cure 100% of patients. That 100% mark is really hard to achieve. If 100% of patients get diagnosed with breast cancer, if not one of them die, that would be phenomenal. But getting up into the 90% range it's a victory in the field of oncology, and we're already seeing that. Pediatric leukemia in the 1950s or 60s had like a 30% cure rate, and now a patient can walk into my office and I can tell them, like, 95% chance we're just gonna treat your cancer, it'll be gone, and 95% of those patients are gonna go on to live long, happy lives. So that's such a victory. That's already progress that's been reflected, and we're just continuing to make more progress. So I don't know that there's, again, going to be a one-size-fits-all cure, but I think we're making a lot of progress, and we have a lot more to go, but we're on our way.
Fantastic. So one last question, just for Dr. Murphy. You guys will understand this. As the sole alum on our stage, besides the fact that you've never been in a 700-person class in your life on campus at Pepperdine, yay. No offense, Dr. Shuri. Talk a little bit about your experience at Pepperdine and how that has informed your obvious success.
Oh man, I could go on for hours probably on this topic. I would say, the education I got at Pepperdine is still, unparalleled, the experiences that I got here. I think I actually benefited a lot by being in a small class. I majored in biology. I got an applied math minor, so Dr. Luke, linear algebra was in there. I didn't have a class of 700. I think I would have gotten lost in a system like that. But instead, I really got to know my professors. I don't know how you did that in a class of 700. But I think I took the initiative to really try to learn as much as I could while I was here. But that work also got reinvested back into me, and so I'll never be able to thank everyone here for everything that was invested in my education. But the values and everything that was instilled in me as a student while I was here has really shaped the kind of physician I am now, right? I can meet my patients at all levels of where they are, on a spiritual, religious side, but also, if not, it helps me to be able to just be a person with them, right? We are all humans, and we meet these patients, in the worst day of their lives. And I think the education I got at Pepperdine really made me, obviously a much better person and a better physician for my patients. So soak up every second you have here. It's not long enough. And I'm so excited for the College of Health Sciences. I think so many of my classmates, at the time, really were looking for guidance in careers in healthcare, and back then, there wasn't as much guidance in healthcare, and so I'm so excited to see how much progress Pepperdine has made, really in trying to advance and expose students to healthcare professions. It's very exciting. I've waited decades for this. So.
Thank you so much.
My name is Lee Katz. I serve here as the Dean of Seaver College. At the beginning of the afternoon session, I just want to thank each and every one of you for being here today, part of this inaugural Oncology Symposium, and investing the time to learn more about this critical subject and the status of the current science around it. Let's just give the morning session a round of applause one more time. One of the things I've appreciated about today's gathering is the organization. This morning we were given the opportunity to learn from experts on the oncology field, the doctors, the researchers, even a patient, all of whom are engaged in the quest to heal others. This afternoon we have the chance to hear from the next generation, the students who will eventually take the baton and continue running that long, but now we know, winnable race to defeat cancer. The student presentations you are about to hear represent one of the trademarks of Pepperdine University and of Seaver College. While many colleges and universities now boast of undergraduate research opportunities in their curricula, at Seaver College it has been a part of our fabric of learning and discovery for decades. On our campus, students are co-creators of new knowledge. They are invited to contribute to every phase of research projects, whether it's an investigation on how drought impacts ferns, the filming of a new documentary, the study of student loneliness. Seaver College students are given the opportunity to get up from their desks, roll up their sleeves, and to learn by doing. Doing the field work, the data collection, the analysis, alongside faculty mentors. In fact, this event itself originates from undergraduate research. Madison, who we heard from this morning, a pre-med bio student, senior at Seaver College, one of the creators of today's symposium, discovered her passion for cancer research as a first-year student. During just her second semester on campus, she joined Professor Antonio Gomez's laboratory here at Seaver, studied the gene editing technology of CRISPR, and heard the call to study cancer biology. Since then, Madison has gone on to internships at the German Cancer Research Center and the Sarah Cannon Research Institute. Both of those experiences inspired her to launch this event. To all the students who are presenting here today, thank you for bringing your knowledge and your creative energy to our campus. Thank you for sharing with us your passion for learning and your pursuit of truth. Please remember, this is just the beginning of a really exciting scientific journey, the very start of your contribution to the world of medicine and science. We really look forward to hearing from you this afternoon. Please join me in welcoming our first student speaker, Seaver College senior Elizabeth Stansberry.
Well, hello everyone. Like Dean Katz said, my name is Elizabeth Stansberry. I am a senior biology major here at Pepperdine, and I'm so thrilled for the opportunity to get to share a little bit about my research at UT Southwestern Radiation Oncology Medical Center this past summer. I was an intern on a project investigating the dose interval effect in the spinal cord, specifically within the field of radiation oncology. So we begin with the question, why study the spine? And the answer comes down to this idea of metastasis that's been mentioned throughout the day today. Metastasis is when primary cancer in a certain cell tissue of the body spreads to a different tissue in the body, and that becomes a really big deal that we need to address. Bone is actually the second most common metastatic site for the 14 most common kinds of primary cancer. And so that means we really need to understand what happens when tumors develop in the spine and how we can address that. So this comes to the question of spinal tumors. So the spine and our spinal cord are responsible for really critical functions of the body. There's a reason why backbone is a metaphor for structural integrity, right? So when tumors develop in the spine, we have all sorts of things we're concerned about. We're concerned about primarily structural integrity. We can see vertebral body collapse when tumors develop in the vertebrae of the spine. We're also worried about threatening neuron protection. So we have these afferent and efferent neurons running in and out of the spinal cord, and when tumors develop in those hollows, we can see compression, pain, paralysis, restriction of sensation and function, and even the critical function of the spine protecting the spinal cord itself. When tumors develop in the spine, that they can press on the spinal cord, our highway of neural function in the body, and that can lead to pain and, again, paralysis. This is a really serious issue that we're looking at when we see tumors develop in the spine. How do we address that? Radiation therapy is a really effective tool for addressing metastatic cancer in the bone, and especially the bone of the spine. So it's important to understand that radiation therapy is typically prescribed with palliative intent. That is, it's intended to stop or slow the spread of the tumor, as well as reduce the symptoms that the patient is experiencing. And so we do see total or partial pain relief in the vast majority of cases. We can even restore sensation and function from those tumors pressing from reducing the tumors that are pressing on the neurons. And we can even promote healthy ossification, that is, the healthy processes of bone building with radiation therapy. But how does that happen? I'm not a particle physicist, and I don't want to get too much into the weeds here, but it's important to understand the biological mechanism of radiation. So at its core, radiation is a delivery of energy, and that can be in the form of photons, protons or even electrons, often by a machine called a linear accelerator. And if you've taken general chemistry, you know that absorbed energy breaks bonds. And that's our understanding of the mechanism of the damage that radiation causes, specifically breaking bonds within the DNA backbone. And this can happen via direct action, meaning that energy itself is breaking the bonds in the DNA backbone, or indirect action, where the energy is absorbed, creating free radicals, which in turn break the bonds of the DNA backbone. And so this is what we're doing when we're radiating the tumor in the spine or the spinal cord. But if you're tracking with me, you may have realized that we have a problem. When we're delivering radiation to patients, we're not only delivering radiation to the cancerous tissue, we're inevitably going to deliver some radiation to healthy tissue, and that's what we're calling the normal tissue issue, right? So treatment with radiation therapy becomes this optimization problem of how can we maximize the dosage that we deliver to the cancerous tissue while minimizing the damage that we cause to healthy tissue. And the field of radiation oncology has developed normal tissue dosage limits, which say how much radiation can we deliver to this patient before they reach this point of toxicity. And when we're talking about neural tissue, toxicity is when we deliver enough radiation to cause the death of oligodendrocytes. If it's been a while since you took physiology, you might need the reminder that oligodendrocytes are the cells that myelinate axons in the central nervous system, which means if we're killing those oligodendrocytes, we're going to cause a whole array of downstream issues. And so we want to avoid that by establishing normal tissue dosage limits that prevent the endpoint of toxicity. This is a critically important study to figure out what is the tolerance of normal tissue. And just to be clear, normal tissue tolerance studies don't just exist in radiation oncology. They exist for chemotherapies, for other drugs, and a lot of forms of treatment. So this is just one specific application of a normal tissue tolerance study. You might also be asking yourself, the radiation oncology field is not new. It's been around for about a century. Shouldn't we know by now how much radiation normal tissues can tolerate? Yes and no. So when the radiation oncology field first emerged, we would radiate wide swaths of the body, and in doing so, yes, cause damage to the tumors, but also cause damage to a great deal of normal tissue. And so, but as developments have occurred, we've been able to become more precise and more accurate with our delivery of radiation, and that in turn changes our understanding of normal tissue tolerance. So a couple examples of those developments: image guidance. So we have MRI and X-ray image guidance that allow us to deliver radiation within a millimeter of certainty of where the tumor is, which is really exciting. Even now, today, patients can receive live tracking with imaging, meaning that as they breathe, the radiation site changes to track with their cycles of lung expansion, which is really incredible. Another change that has occurred within the past 20 years is the development of stereotactic body radiation therapy, which is a real revolution in the dose planning of the delivery of radiation therapy, which is in essence increase in the amount of radiation we deliver while decreasing the number of fractions or radiation sessions that a patient goes in for. And we've found that this can deliver the exact same amount of damage to tissues while decreasing the amount of toxicity that we see in normal tissue, which is really exciting. And then out of SBRT, we've also, in the past 5 or 10 years, there's been a development called pulsar, which is at its root ultrafractionated, meaning increased intervals in between radiation sessions, which again is decreasing the amount of toxicity that we see in normal tissue. So all of these different developments mean that we need adjusted dosage limits because normal tissue can tolerate more radiation when less normal tissue is getting radiated. A brief note on animal testing. So of course, human subjects are ideal, and we do use clinical trials and clinical data in these sorts of studies as well. However, when we're doing a study where we're looking to establish an upper limit, that means that the subjects in the highest dose are going to be receiving radiation that will cause them to develop paresis. And no physician would ever subject their patient to radiation that is expected or known to be too much radiation. And so in these kinds of studies, we do need to rely on animal testing. However, rats specifically have demonstrable generalizability, and their spines and spinal cords act as really great models for the human spine. But anyone who's worried about these rats, don't worry, there's strict protocols from the Institutional Review Board that ensure that we minimize suffering and really promote the health of these rats as we respect and honor their contributions to clinical development. So, the specifics of our study, we had 4 dose groups. That first dose group received 2 fractions of radiation with only 1 day in between, and that was representative of our SBRT radiation. The second group received also 2 fractions with a 3-week interval in between their 2 radiation sessions. The third group just received 1 fraction of radiation, and the last group was a sham irradiation where they were put to sleep and then woken back up without receiving any radiation. Within each of these groups, we had different dose levels, and all of that's going to come together to help us construct a dose-response curve. Our hypothesis was that the split dose with the pulsar distribution, that 3-week interval in between the radiation sessions, would result in the greatest spinal cord tolerance. So a bit about our methods. That's me with our machine, our SARP, Small Animal Radiation Research Platform, which delivered photon radiation via an X-ray at about 220 kilovolts peak. So we would anesthetize the rats with isoflurane, and then our machine actually had a CT imager built in. And so we were able to set the rats up on the machine, capture those CT scans, plan the dose delivery, and then deliver the radiation all in one session, which is really exciting and quite parallel to the experience that a patient would go through when they receive radiation. We radiated parallel opposed fields, meaning we got the anterior and the posterior section of a 5 by 20 millimeter portion of the rat's left spinal cord. But depending on the group and the dose level, the rats received anywhere from 24 to 47 gray, our unit of radiation in total. And then after the rats reached that endpoint of paresis, we moved on to tissue processing with histology to actually look at that radiation damage on a cellular level. So this is just a little side-by-side here of a rat, well, it's not a real rat, in the radiation setup, and then a patient receiving radiation to just see how, parallel those experiences actually were. We truly can't share pictures of the rats to protect their privacy. So the results of our study. So you might be disappointed to learn they're actually still ongoing. Some of these rats are still alive and well. And that kind of extended timeline is expected with a study like this because neurons are slow differentiating cells. It takes a long time to see the impacts and the damage caused by radiation. But we already do have some interesting results. So I'm going to point your attention to this second middle table right here. So as we can see, this highest dose level, all 6 out of the 6 of those rats reached that endpoint of paresis, which is what we expect. If you point your attention to this graph over here, our dose-response curve, we need that highest radiation group to have an 100% chance of reaching radiation. But we need the lowest dose group to have a 0% chance of radiation, and that's not at all what we found. So this is our pulsar 21-day interval. In the lowest dose group, 4 out of the 6 of those rats developed paresis, which is really surprising. It means we're not going to be able to construct a full dose response curve, and we're going to actually have to go back in and do a second round of the experiment to add lower levels of radiation to be able to have this full curve like we need for our meaningful results. But as was mentioned earlier, if we knew exactly what was going to happen and things always turned out exactly as we expected, we wouldn't probably conduct research in the first place. And so even interesting or unexpected results are still clinically significant and exciting to move forward with in application. A brief acknowledgement, my research advisor, Dr. Robert Timmerman, he's the chair of the Radiation Oncology Department at UT Southwestern, and he's actually the man behind the SBRT and Pulsar revolution in radiation oncology. And so it was a really great honor to work under him, and I'm very grateful for his leadership. And then to all the students in the audience, I just want to encourage you all to apply to participate in research. This research was outside of Pepperdine, but I'm also honored to have had the opportunity to participate in multiple research projects and groups at Pepperdine, and there's me with my Pepperdine research advisor, Dr. Lucas, at a conference this past spring. So just a brief word of encouragement. You're not underqualified, you're not underexperienced, and you should put yourselves out there and apply to participate in research. Thank you all so much for your time. I really appreciate it.
Hello, everyone. My name is Sophia Palumbo, and I'd like to begin by thanking Madison Johnson, the Natural Science Division here at Pepperdine, and for all the panelists and speakers that we have the pleasure of hearing from today. I'm so excited to share my summer research with Dr. Anna Weiss, who's a breast cancer surgeon seeing both benign and cancer patients at the University of Rochester Wilmot Cancer Center. I'm excited to share our findings of a large cohort of breast abscess patients with breast abscesses and looking at two clinical questions that commonly come up in practice: socioeconomic disadvantage and treatment strategy. What is a breast abscess? A breast abscess is a localized collection of pus that impacts both lactational and non-lactational patients. In lactating patients, this commonly occurs due to mastitis. However, in non-lactating patients, this typically arises from a break in the skin. This can be due to a nipple piercing, trauma to the nipple, as well as other procedures. Similar features present themselves in patients diagnosed with breast cancer. We see symptoms like pain, swelling, warmth, and tenderness, and this can result in misdiagnosis as breast cancer. So today, I plan to look at what we will be studying as a misdiagnosis of breast cancer, which is a breast abscess. Prior literature shows that recurrence is common among these patients, with risk factors such as diabetes, smoking, and nipple piercings. With recurrence comes prolonged antibiotic courses, longer hospital stays, and other complications with additional treatment. Despite how frequently we treat this condition, there's surprisingly limited large studies looking at how this impacts individualized treatment decisions. So there's three main treatment modalities commonly used in the clinic. The first is antibiotics. This treats the underlying bacterial infection and is the least invasive. The second is ultrasound-guided aspiration. This involves using ultrasound to locate the collection of pus and also to guide the needle into the abscess and then drain it. This remains the gold standard among clinicians for common practice in the clinic. And lastly, we have I&D, which stands for incision and drainage, where we make an incision, insert a catheter, and drain the pus that way. This is typically the most invasive modality out of the three treatments. However, it's typically only used for complex breast abscess patients. Clinicians regularly choose between these three treatment modalities. However, there's limited research as to what outcome or what treatment actually has the best outcome. So as we know, with this limited research, it can make it difficult to understand what patient risk factors actually contribute to delayed resolution and recurrence. Specifically, socioeconomic disadvantage has shown to impact outcomes with other treatments, like follow-up challenges and adherence to antibiotic courses. However, this has not been rigorously studied among breast abscess patients. Without strong data, we rely on experience rather than evidence to tailor these treatment plans to our patients. This creates variability and uncertainty as to which treatment modality actually proves as the best possible mechanism. So, in my study, I aim to understand what risk factors patients experience and how that impacts our two outcomes. The first being resolution within 30 days, and the second is recurrence within 1 to 6 months. We hypothesized that patients that had higher deprivation index scores and those that were treated with more aggressive treatments like incision and drainage were more likely to recur and less likely to resolve. We measured socioeconomic status using an area deprivation index, ADI. Essentially, we use the patient's zip code. It gets correlated to a scale on 1 to 10, with 10 being associated with the highest level of area deprivation index. So this would relate to housing quality, education, income, and other factors. Additionally, our two co-primary endpoints were defined as resolution within 30 days of initial treatment of the primary abscess. The second co-primary endpoint we defined as was recurrence within 1 to 6 months of initial treatment of the primary abscess. So how did we conduct this study? This was a retrospective study approved by the IRB, and we used two institutional sources. The first was the Picture Archiving and Communication System, commonly referred to as PACS. This included all patients that underwent ultrasound-guided imaging and had a breast abscess indication. On the other hand, we had TriNetX, which was a database we queried using procedural and diagnosis codes related to a breast abscess. With these two databases, we compiled patients, yielding the largest known single institution breast abscess patient cohort. Once we gathered the patient data, we were able to analyze the patient characteristics. The first test we ran was a chi-squared analysis test to compare patient characteristics across our two outcomes. We then followed that up with a hierarchical logistic regression test to evaluate the independent association of patient characteristics with our two outcomes. This allowed us to adjust for confounding factors rather than relying on univariate association. So here's our patient cohort. We began with 1,179 patients. A significant amount of these patients were excluded due to previous biopsy or recent surgical history, and so that left us with 693 patients that met study criteria. As you can see at the bottom, you can see the breakdown of the treatment types among our 693 patients, with antibiotics having the most abundant, then ultrasound-guided aspiration, followed by I&D. So you can see there's clear variability among the treatment types across our patients. In addition, we also had a very medically complex population. These are all different patient characteristics that have been shown in prior literature to contribute to risk factors of developing and recurring breast abscesses. So over half our population were smokers, over 70% had diabetes, nearly 60% were obese, the mean age was 41, and we had a racially diverse clinical population. These comorbidities are all clinically relevant for increased infection and wound healing. So moving on to our two co-primary outcomes. You can see on the left-hand side, we have resolution within 30 days. We were surprised to see that almost 35% of our population did not resolve within 30 days. On the other hand, we have recurrence. Almost 80% of our population didn't recur, which we were happy to see. However, 20% were still suffering with prolonged symptoms, likely requiring additional treatment, whether that was something simple like antibiotics or something more invasive like incision and drainage. So moving on to our analyses, we began with a chi-squared analysis test to understand the potential risk factors related to our two outcomes, resolution within 30 days and recurrence within 1 to 6 months. For each variable, we're comparing the patients that resolved versus did not resolve and those that recurred with which didn't recur. And we found that non-Hispanic, non-smoking, non-lactating, those that had a high area deprivation index score, and those that were treated by ultrasound-guided aspiration were more likely to resolve within the 30 days. On the other hand, with recurrence, we found that patients that had a nipple piercing, were smoking, or lactating were more likely to recur. What stands out most is that socioeconomic disadvantage had no correlation with either delayed resolution or recurrence. Similarly, treatment modality across all 3 treatment types did not show a significant association with recurrence. This suggested that observed outcomes were not driven by socioeconomic status or initial management approach alone. So we followed this up with a multivariable analysis. This allowed us to control for confounding factors. We controlled for factors like patient age, abscess size, ADI ranking, diabetes, smoking, nipple piercing, and lactation status. We found again that socioeconomic disadvantage had no independent correlation with either of our outcomes. The only factor associated with non-resolution was lactation status. Specifically, those that were previously lactating were less likely to resolve. Again, treatment modality also remained non-significant, suggesting that antibiotics, ultrasound-guided aspiration, and incision and drainage had similar outcomes regardless of the treatment type, all accounting for disease severity and patient characteristics. The only variable that was significantly associated with occurrence within 1 to 6 months was size, specifically abscesses greater than 5 centimeters, had a higher odds of recurring. Again, it was surprising to see that socioeconomic disadvantage and treatment strategy had no independent association with either of our outcomes. Clinically, this suggests that disease burden, rather than socioeconomic context or treatment modality, is the main driver of recurrence risk. So, in this large series of breast abscesses, ADI has no correlation with delayed resolution or recurrence. Additionally, size as to treatment modality was the only factor associated with recurrence. This is likely in part due to the appropriate triage that providers are taking to treat their patients in clinic. However, it's also a limitation of this retrospective study. Given the fact that all three treatment modalities had equal outcomes, regardless of whether you were treated by antibiotics, ultrasound-guided aspiration, or incision and drainage, we would recommend that ultrasound-guided aspiration should remain the front line for provider choice for treating breast abscesses. This is due to its limited invasiveness and good cosmetic outcomes. This work was preliminary data for a collaboration project between Dr. Weiss, Dr. Barron, and myself, using photodynamic therapy to treat breast abscesses. The study began treating intra-abdominal abscesses and now has shown to be a feasible mechanism for treating breast abscess as well. If this is the case, this would allow us to avoid opening up the breast and improving patient cosmetic outcomes for both primary and post-operative breast abscesses. Again, I'd like to thank Dr. Weiss for her incredible mentorship throughout this process and for Pepperdine University for hosting an amazing event. Thank you.
Hello everyone, my name is Luke Ponterero, so I'm a senior bio major here at Pepperdine.
Hi, I'm Joan Arguns-Kolek. I'm also a senior bio major here at Pepperdine.
Yeah, so our research today is going to focus on the association between immunogenic variation along with the breast cancer in the context of the breast microbiome itself.
So a little bit of background on our research. I'm going to tell you a little bit about how the host and the microbiome interact when someone has breast cancer. So why breast cancer? Breast cancer affects 1 in 8 women around the world, with a large proportion of these diagnoses not being attributable to genetic or environmental factors. One angle to take is that there's growing evidence of the role of the breast microbiome in breast cancer, but how the microbes interact with the host is not entirely understood. Furthermore, there is evidence of the immune system and the microbiome co-evolving, but how these interact in regards to breast cancer pathogenesis is not entirely understood.
So yeah, just kind of moving on, before we jump into all of the results and all that, so we should define what the microbiome is. So it's a collection of trillions of microbes that are within our bodies or even on our bodies, on our skin. So those microbes can have a beneficial effect, or they can just be on our skin and have no impact on our health. So the microbiome exists in 2 states. So the first one's the eubiotic, and that's the balanced state of the microbes. And then there's another state called dysbiosis, and that's when there's an imbalance of those microbes within us. And that's most often due because of antibiotic usage or a change in diet. And dysbiosis, which is, again, that imbalance in the microbes, can lead to the invasion of pathogenic bacteria, which can lead to metabolic diseases and immune-mediated diseases and cancers.
Moving on to the breast microbiome. So when you think of the microbiome, most people think of the skin, the gut, the mouth, but the breast itself has its own distinct modifiable microbiome. Yes, so it exists in eubiosis and dysbiosis. When you do have a dysbiotic breast microbiome, this is associated with disrupted immune invasion of the breast and also disruption of inflammatory processes in the breast. Our lab has been able to find a distinct microbial signature in patients with breast cancer and without breast cancer. And so this suggests that the microbiome in a healthy person plays a role in potentially protecting them from breast cancer initiation and or progression.
So yeah, just moving on to previous research conducted in our lab. So our lab looks at the breast tissue microbiome and its interaction with the human host. So we look at 4 tissue types. So these ones right here. First one is healthy. Next one is pre-diagnostic. So that is healthy tissue before a formal breast cancer diagnosis. And then adjacent normal, so that's tissue that is next to a tumor in the sample. And then we have samples that are tumors themselves. So our work has looked at the composition and microbial function of those microbes and how it leads to a potential microbial signature that comes before the onset of breast cancer. So in the figure up here, we have the different tissue groups, so healthy, pre-diagnostic, adjacent normal, and tumor, and then the differing abundances of the microbial taxa along the y-axis here. So our work has shown that bacteria exhibit different functions within the breast depending on if the tissue is healthy or if it's cancerous.
Yes, so honing in specifically on the immune system and the breast microbiome, how the varying microbial signatures when you have breast cancer and when you don't have breast cancer interact with the host genome is not entirely understood. But there is evidence of the microbiome interacting with the breast tissue immune network. So we decided to investigate how the breast microbiome interacts with genes involved specifically in the breast tissue immune network, and this motivated our hypothesis.
Yes, our hypothesis for this experiment was that we would see immune genetic variation and an association with altered abundances of those microbial taxa, along with alpha diversity in the host, within the context of the breast microbiome. So moving on to methods.
We had samples from, We had samples from 60 women who donated, well, we had samples from 45 women who donated 60 samples to the Susan G. Komen Tissue Bank at the Indiana University. And from their samples, we conducted whole genome DNA sequencing. And from there, we filtered our sequencing data to only include high impact genes and genes with a quality score over 55. Previously in our lab, they conducted microbiome sequencing on these same tissue samples, and they were able to find specific ASVs, which are amplicon sequencing variants, which are DNA sequences that essentially act as DNA barcodes to specific microbial taxa. So they found these ASVs that were associated with cancer, and then
from there, so we looked at the immune genes and ran linear regressions on those. So specifically those 4 tissue types, so H, PB, AN, and T. And just a special note to each of those groups had 15 samples each. From there, we proceeded to use Maslin-2, which is our studio package, and associate the ASV abundance with the alternate allele frequency and genotype of those immune genes. So as far as results, so we looked at 18 immune genes, so those are genes that had some sort of immunological function. Of those 18, 13 had significant associations to microbial ASVs, 5 of them did not. And then from there, we looked at 4 specifically, since they had the most number of microbial ASVs, while the other 9 did have some, but not as many.
So our 4 genes are AKR1C3, which is a gene involved in prostaglandin synthesis. Our second gene is ARG1, which suppresses T-cell activity. Thirdly, we have CCAM21, which is involved in T-cell activation. And lastly, PRAM1, which codes for a protein involved in the complement system. So again, these are our genes, and these are the specific taxa we found them to be associated with. But specifically, we decided to focus on Pseudomonas for AKR1C3, Pseudograssylobacillus for ARG1, Streptococcus for CCAM21, and Staphylococcus for PRAM1.
Yeah, so zooming in on those immune genes, those 4 focus genes. So we'll start with the AKR1C3 gene itself. So in the figure up here, we can see the alternate allele frequency of that gene and then the Pseudomonas ASV15 abundance along the y-axis. So Pseudomonas itself is a bacterial genus that's been found to secrete anti-tumor molecules. And from our results, we found that the healthy and the pre-diagnostic individuals showed higher alternate allele frequency compared to the other groups.
And then to your over here, we have the genotype for AKR1C3. So the mute genotype was associated with a lower abundance of the Pseudomonas taxon. And with this suggests that the reference allele of AKR1C, since it has a higher abundance of Pseudomonas, is associated or could provide potential protection against breast tumor development.
Yeah, and then moving on to ARG1. So we looked at ARG1, and that's a gene involved in suppressing T cell activity, so having an immunological function. So similar to left, for the other gene, we did ARG1 alternate allele frequency, and then against the Pseudogracilis bacillus taxa. So there is not much known about that taxa and its involvement in breast cancer, but we did find that the AN and T tissue types display the higher alternate allele frequency when we tested that.
Looking at the genotype of ARG1 associated with Pseudogracilis bacillus, ARG1's mute genotype is mainly seen in cancerous tissues, and they're associated with a greater abundance of Pseudogracilis bacillus. So this suggests that the alternate allele of ARG1 could predispose you to Pseudogracilis bacillus colonization in breast cancer patients, which highlights another host microbiome interaction that may influence breast cancer risk.
And then moving on to CCAM21. So again, that is a gene involved in T cell activation. So we looked at that, the alternate allele frequency, and then the Streptococcus abundance. So Streptococcus itself is involved in cancer-associated samples, and from our results, we found that the PD, AN, and T groups had higher alternate allele frequencies compared to the healthy group.
Yes, and then looking at genotype again, the Streptococcus abundance is greater in the mutated genotype. And again, something that's very interesting about Streptococcus is that it's a common genus found in dysbiotic microbiome. So this suggests that the mutated allele of CCAM21 could predispose you to that dysbiosis that's found in breast cancer.
And moving on to PRAM1. So again, it's a gene involved in optimum neutrophil activity and immune cell function. So when we ran the alternate allele frequency, we found that the H and PD tissue types showed higher alternate allele frequency compared to the other groups.
And then in looking at genotype again, the Staphylococcus abundance was lower in the mute genotype. And as you can see here, the only samples with the mute genotype are the healthy samples. So this suggests that the mutated allele actually could reduce colonization of the breast tissue with Staphylococcus in healthy patients, showing again another host microbiome interaction that influences breast cancer risk. Yes.
So yeah, moving on to conclusions and future directions. So of those 18 immune genes that we looked at, 13 of them had significant associations to the bacterial taxa. So our work suggests that certain bacteria are associated with genetic variation in the context of breast cancer.
And finally, for future directions, our work highlights the possibility that people could be genetically predisposed to a specific breast microbiome composition, which also might contribute to their predisposition to breast cancer development. Right now, our next step in our lab is working towards finding out whether the microbial taxa that we identified are associated with alterations in expression of the genes that we focused on. And in the future, because our cohort was so small, we only had 45 women, we hope to replicate the study with a larger sample size. And we would just want to acknowledge and thank Dr. Steemsma for leading our lab and being our mentor through every step of the way. I want to thank my fellow lab mates, Luke.
I want to thank Joan too.
Yes, and thank you all for listening to us. Thank you, Madison, for organizing, and everyone else in charge. Yeah.
Hello, everyone. My name is Chloe Nakora Scruggs, and today I will be presenting a project that explores whether reactivating epigenetically silenced genes with CRISPR-A technology can help suppress tumor growth in triple-negative breast cancer cells. So we'll be moving through the initial motivation, the developed hypothesis, the methodology, and finally the data and foundational results. So as researchers and clinicians conduct studies and trials to create effective therapies, they face multiple differing challenges. Firstly, tumors are made up of different cancer cells, not a simple uniform population, so they require different approaches in order to suppress or activate genes. When cancer cells are treated, although the drug is mostly effective, there are a few surviving cancer cells. And as these cells are adaptive, the surviving few become drug resistant, and cancer comes back, often worse than before, because it's developed new resistance to these previous therapies. Although cancer cells share core mutations, each cell has unique additional mutations and different altered regions of chromosomes. So essentially, cancer is not one target, it's many targets at once. Epigenetics also plays a large role in the treatment of these cancer cells, and as genes can be suppressed or activated even without DNA mutations. So while some regions are active, others can be silenced by histones. And the epigenetic state controls which genes are expressed, affecting tumor growth, drug response, and eventually patient outcomes. Although there are many modern-day effective treatment methods, there are limits. Chemotherapy and drug-based therapies have been proven effective in shrinking tumors, but they rarely eliminate all cancer cells. This presents a challenge particularly evident in triple-negative breast cancer. As triple-negative breast cancer lacks targeted therapies and relies heavily on chemotherapy, it develops chemoresistance, which often worsens patient outcomes and increased mortality. These limitations highlight the need for alternative approaches involving new technologies that move beyond drug-based killing. So these limitations of drug-based therapies raise the question, if we can eliminate every cancer cell, could we instead suppress tumor growth by reactivating genes that cancer cells have turned off? In order to fully unpack this initial hypothesis, it's important to understand what gene suppression means at the epigenetic level. In many cancers, tumor suppressor genes are not mutated, but rather epigenetically silenced. The gene is still present in the genome, but its expression is turned off through chromatic modifications. It's important to note that epigenetically silencing is reversible. So if we can reactivate those suppressed genes, we may be able to slow tumor progression across genetically and epigenetically diverse cancer cell populations, rather than selectively killing off only the sensitive cells. With this understanding, we can now better understand the questions that drive the foundational project and move on to our hypothesis, which is, could we use CRISPR activation to identify new therapies to fight cancer? Despite genetic diversity, breast cancers may share genes that are commonly epigenetically suppressed. Because this silencing is reversible, reactivating these genes could suppress tumor growth across heterogeneous cancer cell populations. To further test this, CRISPR-based gene activation was used to systematically identify potentially suppressed targets in triple-negative breast cancer cells and reactivate them. There we go. Firstly, CRISPR is an acronym for Clustered Regularly Interspaced Palindromic Repeats, and this technology has proven itself a modern, useful tool in working towards effective oncogenic therapies as a way to improve patient outcomes. But it's important that we look at the distinction between CRISPR editing and CRISPR activation. CRISPR editing refers to bringing a guide RNA to the exons in order to inactivate that specific gene. This is a permanent change to the DNA, forcing it to repair itself. However, CRISPR activation, or CRISPR-A, does not involve DNA splicing. Rather, the Cas9 enzyme targets the promoter and uses activation domains to rather turn on or reactivate the gene that is being suppressed by the cancer cells, presumably due to its toxicity. As shown in the image here, CRISPR-A targets the promoter rather than the exons, which is a distinctive and useful difference for this experiment. It's helpful to think of CRISPR-A as a mail delivery system. The dCas9 serves as a mailman carrying the activation domains, or the packages, to the address, which is the guide RNA. The dCas9 enzyme grabs hold of the guide RNA to form a complex, which is the completed system. The guide RNA's dress is specific base pairs, and as it latches onto the DNA, it causes the DNA to unwind, forming a DNA bubble. And as it's unwinding the DNA, it's scanning for the complementary sequence. And once it arrives at that sequence, the delivery address, it delivers the activation domains to reactivate the suppressed gene that is toxic to cancer. Here's the completed complex with the activation domains, the dCas9 enzyme, and the guide RNA latched onto the DNA, and it's unwinding it, forming that bubble. Understanding this complex allows for the formation of methods used to test the hypothesis. The first step in reactivating suppressed genes is determining where to target. CRISPR-A has to bind near the promoter, and that's determined by the transcription start site. This region functions like the ignition of a car, so activating it here starts the entire process. The exact DNA nucleotide corresponding to the 5' end of the mRNA transcript marks where to begin the transcription. The ideal place for activation is between -150 to -100 base pairs to produce the strongest gene activation, which sits just upstream of the transcription start site. To start the experiment, we used a pooled CRISPR-A screen, and to do so, each guide RNA was packaged with the puromycin resistance gene and introduced into a stable triple-negative breast cancer cell line expressing the CRISPR-A machinery. The puromycin resistance gene acts as a selection marker to ensure that only cells that have successfully received the CRISPR-A mechanism survive. So after the puromycin selection, we were only working with CRISPR-A treated cells. These cells were then cultured over time and monitored to show how the activation of each individual gene affected cell growth. To further specify this experiment, we used the HCC 1937 breast cancer cell line, and with this experiment, we assayed 18,885 different genes simultaneously with the CRISPR-A mechanism. To further prove our hypothesis, our findings were validated by this Western blot comparison of HCC 1937 cells without CRISPR-A and HCC 1937 cells with the CRISPR-A complex. Essentially, this shows if an activation gene slowed proliferation, the cells became underrepresented in the population. Likewise, if a suppressed gene is activated, it would become present in the population, contributing to the growth of cancer. Finally, next-generation sequencing was used to quantify which guide RNAs were lost over time, allowing us to identify candidate growth suppressor genes that could be activated, leading us to our data and results. To better understand the potential roles of candidate genes identified in our screen, it's important to compare how they are expressed in healthy versus cancerous cells. Differences in expression pattern can provide insight into whether a gene may function as a tumor suppressor or play a role in tumor progression. Here, these are graphs from MyPanda, which is a large-scale gene expression database containing over 20,000 human healthy and cancerous samples. In this dataset, healthy tissue expression is shown in blue, and cancerous tissue expression is shown in red. Here we highlight two genes, SAMD9L, which is suppressed in healthy cells, and CDK11, which is expressed in healthy cells. And these two contrasting genes serve as a starting point for further data comparison. Taking a closer look specifically at breast cancer, gene expression data shows that SAMD9L is amplified in breast cancer, while CDK11 is significantly reduced, which is opposite of their expression in healthy cells. While this dataset does not establish the cause, the suppression of CDK11 may reflect selective pressures against its expression if activation impairs tumor cell viability. These expression patterns further support investigation into their potential functional roles in breast cancer progression. The elevated expression of SAND9L and suppression of CDK11 highlight how different genes may be differentially regulated. And in the context of our CRISPR-A screen, identifying genes that are commonly suppressed yet growth inhibiting when reactivated may reveal therapeutic targets. Based on our data collection and confirmation of gene behavior in healthy and cancerous cells from MyPanda, the lab was able to establish a gene library of the top 20 ranked genes for each class of cell growth effects, which are divided up by different gene phenotypes in normal cells. The image on the left shows epigenetically repressed genes to slow or stop cell growth, while the image on the right shows epigenetically activated genes with enhanced replication. This became the basis of our experiment here at Pepperdine University under Dr. Antonio Gomez. Building on the results of our genome-wide CRISPR activation screen that identified epigenetically regulated gene effects affecting triple-negative breast cancer cells, and using the categorized gene library by these gene effects, we established a strong starting point for continuing studies that we completed this year. We chose 4 growth suppressor genes, 3 growth promoting genes, and to broaden the scope of our understanding, we used the MCF7 breast cancer cell line, which is estrogen receptor and progesterone receptor positive and classified as a luminal A subtype, which allows us to better assess whether the functional effects of these genes extend beyond the triple-negative breast cancer into a more hormone-responsive model. Building on the foundational project of identifying growth-modulating genes in triple-negative breast cancer, the next phase of the project seeks to understand how CRISPR-A has driven transcriptional activation, which affects the MCF7 breast cancer cell line, which will be presented on by my partners Jessalyn Chen and Catherine Nguyen. I just wanted to quickly acknowledge Dr. Gomez and his foundational work that not only provided the data, but the understanding for us to move forward with our project, to Jess and Kat, whom this project would not be possible without, and to Madison and all involved for putting on this incredible event. Thank you.
Well, hi, everyone. We want to give a big shout out to Chloe. Thank you so much for getting us started on CRISPR-A in cancer. My name is Jessalyn.
And I'm Catherine.
And we will be introducing the next step from the previous presentation, discussing CRISPR-A-mediated activation and how it reveals proliferation dynamics in ER-positive breast cancer cells. Okay, just to quickly get us started, we're going to go into a little bit of introduction and background, mainly our motivations, and then we'll get into methods, data analysis, and finally finish with our discussion and conclusions. Okay, so Chloe mentioned in her presentation about the difference between CRISPR and CRISPR-A. I just wanted to get into it a little bit again. We wanted our research project to further the hypothesis of using CRISPR-A in genes for cancer. And so just to show you the difference one more time, CRISPR in its original state has the ability to navigate to target sequences, and it cuts the DNA there. The difference with CRISPR activation is it uses dead Cas9, which is the dead version of the enzyme. It navigates to those target sequences, but instead of cutting it, it actually activates kind of the promoter region to begin transcription.
So, one common misconception in cancer is that it only arises from genetic mutations in DNA. However, it's also important to note that cancer can also arise from epigenetic alterations, and these are non-genetic, reversible changes that silence or activate previously non-mutated genes. Such changes can influence cancer cell replication, tumor progression, and even responses to therapy. A major challenge in developing cancer therapies is tumor heterogeneity, and this basically refers to how tumors contain diverse cell populations with both genetic and epigenetic mutations that cause them to respond differently to treatment. While some cells are susceptible to therapies, others are resistant and may continue to multiply. So our interest in the role of epigenetically silenced genes in cancer led to our research question. We asked, can we target epigenetically silenced genes in order to create gene-specific therapies? And furthermore, can activating these genes via CRISPR-A alter cell proliferation? So we hypothesized that targeting these specific genes and activating them via CRISPR-A does have the potential to slow cancer cell growth. We hope that one day gene-specific therapies can be used in conjunction with other existing therapies in order to result in no outgrowth of cancer.
Okay, so what we're looking at here is a condensed version of the CRISPR screen that Chloe kind of brought up earlier. So we ended up picking 7 genes that showed evidence of involvement in cancer proliferation. So these 4 are genes from the very top of the list, and these were hypothesized to decrease cell proliferation, while these next 3 are from the bottom of the CRISPR screen, which were hypothesized to increase cell proliferation.
Although our CRISPR screen identified candidate genes in the triple-negative breast cancer HCC 1937 line, we switched to MCF7 for higher culture stability and ease of use. MCF7 models estrogen receptor positive or ER positive breast cancer, and unlike triple-negative breast cancer, it contains receptors for the hormone estrogen. Making the cell line switch allowed us to assess the transferability of our CRISPR screen findings beyond triple-negative breast cancer and into the more hormone-responsive ER-positive breast cancer. MCF7 is also currently the benchmark for new drug testing, and there's a plethora of existing breast cancer research that uses this cell line. The specific line we're using in our study is also engineered to have the CRISPR-A system in it.
Okay, so moving into our genes of interest, for this discussion we decided to share 2 out of the 7 of the genes that we analyzed. So the first gene of interest was from the top of the CRISPR screen, which was hypothesized to decrease cell proliferation. So CPE is a gene that codes for a prohormone processing enzyme, which just means that it's involved in the biosynthesis of peptide hormones and neurotransmitters. And so according to the literature, although the literature actually says, and is kind of agreed on, that CPE might increase cancer cell proliferation, we found it was really, really interesting that because of the CRISPR screen, we found that it might decrease cell proliferation, so that was something we really wanted to look at. The second gene of interest is from the bottom of the CRISPR screen, which was hypothesized to increase cell proliferation. It's paired box 8 and it codes for transcription factors, and it's kind of involved in tumorigenesis. So it was kind of a little bit different for this gene, where we found that our hypothesis also kind of matched up with what was in the literature, and there was already kind of evidence that it was involved in cancers, so we wanted to kind of check that out too.
So in order to activate our genes of interest in the MCF7 cells and to assess their effects on growth, we transfected specific guide RNAs into dCas9 expressing cells. The purpose of transfecting or introducing these specific guide RNAs is to guide the enzyme dCas9 to target sequences, thus enabling CRISPR activation. We transfected specific guide RNAs of different genes into a 24-well plate and monitored cell growth for 3 to 5 days. We then analyzed our growth using a visual growth curve along with quantitative metrics such as slope, doubling time, and absolute cell density. We repeated this experiment across 3 trials, adjusting parameters such as initial cell number, viewpoints per well, and days recorded each time in order to improve data quality. Something important to note is that increasing the viewpoints from 1 to 5 per well allowed us to take averages of cell density and growth rates in those trials.
Okay, so I'm about to show you a video. This is how we monitored our cell growth. On the left-hand side, you're gonna see a frame that shows our control. These are untreated cells. And then on the right-hand side, you'll see the cells when they're treated with the CRISPR-A, and the CRISPR-A is activating the gene CPE. for all you cell bio students and anyone else, I'd like you to watch out for cell division and cell motility, maybe how quickly the cells are moving, how quickly they're dividing, because that's kind of what we were trying to monitor. Okay, pretty cool. So we're gonna kind of, let's see if we can. Okay, we're moving into results now. So with these videos and images, we were actually able to quantify our cell growth into numbers, and we plotted them against time. So we then calculated the slopes of each line before a visually determined plateau. And so in simplest terms, if the slope of the treatment is smaller than the control, then we associated it with a slower growth rate. So this first graph right here, let me see if I can show you, is from our first trial where we had 1 viewpoint per well. And you can see that kind of right here at the beginning, this red line, which is the CPE, the treatment, kind of has this weird increase, and then it kind of plateaus. But overall, the slope was smaller. That's what we ended up calculating. So this second graph is from our second trial, in which we had 5 to 6 viewpoints per well, which meant that we could take an average of all those viewpoints and then plot that against time instead. Right here, you can kind of see there's a little bit of a steeper incline right here than when compared to the control, which is the gray line, but then it begins to plateau beneath the control while the control continues to grow towards more confluency. Okay, and our third and final trial, what's interesting about this one is that the growth of CPE, although having a flatter slope overall, looks a little more similar to the control. And so these were kind of things we were looking out for when we were measuring growth rates. And another thing we wanted to touch on is now that we have all of the graphs on the screen, you can tell that one looks a little bit different than the rest. And this was really interesting for us because we had to decide if right here, this kind of extreme growth at maybe until about hour 10, if that was due to a biological reason or if it had something to do with maybe our experimental setup. We kind of concluded, based on looking at the second 2 graphs, that it might have been an experimental thing and maybe not biological. And so for this reason, we omitted the first 6 points when we were calculating that slope. But overall, when looking at all the calculated slopes for all 3 graphs, the data supports our hypothesis that CPE might be slowing down the rate of cell growth. Okay, so we did a couple more analyses for our data. This is specifically trial 2, and the difference from this graph and the one that it was in the middle from the last slide is that we normalized the start points of both curves to start at the same percent density, and then we also included the error calculations to kind of show that what each viewpoint was contributing to the average. So in the table to the right, you can see that we calculated mean doubling time up until hour 20, and then we also calculated absolute density from the area under the curve. When you're looking at mean doubling time, you can see that in that table, CPE actually has a smaller mean doubling time than the control, which is interesting. That might insinuate that CPE was actually growing faster than the control. And so we had to take that into account. But looking at this graph, it's up until about hour 20. You see this increase when compared to the control. We had to think about how long does CRISPR take to completely activate inside our cells, and we did a little bit of literature research. It's anywhere from 20 to 40 hours. So taking that into account, we don't know for sure if the CRISPR system was activated until maybe past hour 20. And that's kind of confirmed when you look at the absolute density calculations for the area under the curve. Right there on the table to the right, CPE has a much lower absolute density than the control, which means that in the same amount of time from hours 20 to 73, we actually had less overall growth.
So moving to our second target gene, PAX8, we will be showing another video monitoring cell growth alongside our control. So the left frame has our control, while the frame on the right shows cells treated with PAX8. And as mentioned before, CView can notice things such as cell division and cell motility. And again, from these videos and images, we were able to generate growth curves for cells treated with PAX8. We had to exclude one trial because it exceeded 60% cell confluency at the start time, which basically means that its initial cell density was too high for us to generate a meaningful growth curve. So for trial 1, excluding the first 6 points due to a perceived issue in recording, it resulted in a growth curve that looks similar to our control. And we actually calculated the slope for this, and cells treated with PAX8 had a lower slope than our control. For trial 2, in the first 20 hours, it actually looks like cells treated with PAX8 grew much faster than our control, which is seen by the steeper blue line. Cells reached confluency at around 70% and began to plateau or level out before continuing to grow again. So although the calculated slopes for treated cells in both trials were lower than the control slopes, results are still unclear. Therefore, just looking at the images and the slope values alone doesn't necessarily tell us the full story, and we had to ask ourselves what was happening biologically. Perhaps in trial 2, PAX8 wasn't activated by CRISPR-A until around the hour 20 mark, which is why we see cell growth beginning to slow at this point, but not earlier. And similarly to how CPE was analyzed, we took trial 2 data and we normalized the curve to start at the same initial density. From 0 to 20 hours, we can see that the mean doubling time for cells treated with PAX8 was smaller than our control. This suggests that our cells treated with PAX8 was actually growing faster than our control. However, absolute cell density calculations from 20 to 73 hours actually tells us a different story. It suggested that our control cells were growing faster than our PAX8 cells. And this is an interesting finding considering our initial hypothesis that PAX8 would proliferate cell growth because that wasn't observed during the entire experiment recording. So based on our results, PAX8 does not completely support or refute our hypothesis, but it's something we're still discussing. We want to continue to analyze our data and potentially come up with new hypotheses in order to better understand PAX8 gene involvement. Moving on, this is a box plot showing a comparative analysis of absolute cell density for our 2 target genes compared to our control, which is leftmost. This data was calculated from trial 2, again from hours 20 to 73. The box plot shows the distribution of the data from our area under the curve calculations, with individual data points representing the multiple viewpoints in each well. We can clearly see that CRISPR activation of our target genes resulted in a different growth pattern than our control, with both treatments showing less overall growth. As encouraging as this is, we are still running statistical tests in order to determine any significance.
Okay, so to get into a quick summary of our results, we kind of came up with 3 things that we felt our experiment really told us. So the first one is that we successfully determined that CRISPR activation of selectively epigenetically silenced genes results in differing growths from a control. And that was kind of evident in those graphs that you saw. The second one, which is pretty exciting, is we kind of supported our hypothesis of CPE's ability to decrease cell proliferation. And that was kind of seen in the slopes that we calculated, the area under the curve, which was absolute density, and as well in that video that you just saw earlier. The last part, the third thing, and maybe the most exciting thing that we were able to find out was that we were able to highlight discrepancies between our hypothesis and our research versus the research that's existing out there. And it's actually really cool because it opens up the conversation for alternate hypotheses and the role of genes at the epigenetic level.
So moving forward, our initial priority is to standardize our transfection protocol, and this would allow us to generate more replicable data in future trials. We also want to use our preliminary gene findings as the foundation for creating a CRISPR screen for ER-positive breast cancer. And to bridge our gene findings and broader breast cancer research, we have 2 initial thoughts. First, we would like to use qPCR to quantify the magnitude of mRNA production in order to determine the time point of maximum CRISPR activation. This would help us determine how the timing and magnitude of gene expression directly affects cancer cell growth rates. Secondly, we would also want to contextualize our findings with existing literature. We want to see how our gene findings either support or challenge current studies, ultimately leading to a deeper understanding of epigenetic gene involvement in cancer.
And for some acknowledgements, we want to thank Dr. Gomez, our mentor, for supporting us these last 4 years. We want to thank the Pepperdine Natural Science Division for funding and for allowing us to research at this caliber. We would like to thank our lab members, both past and present, for their continuous support. And finally, to Madison and Chair Smith for planning such a wonderful event to highlight student research. Thank you.
Thank you so much.
Right, wonderful. Well, hello everybody again. My name is Madison Johnson. I'm a current senior here at Pepperdine, majoring in biology on the pre-medicine track with a minor in German. And it's my great pleasure to share with you today the research I was able to do at the German Cancer Research Center in the Cancer Epigenomics Division under Dr. Ashish Goyal. This was something I got to do after my semester abroad in Germany my sophomore year, so really excited to share this project with you all. So let's get into it. This is going to be an overview of the day. I'm going to give you guys some background. We're going to move into the actual experiment that I did, and we're going to end with some exciting analyses that I think really give you an idea of how we tie the project all together and also our future directions as we continue on with this project. So let's get right into it. For background, so I think it's always great to review the central dogma of biology. So some of our students here know we have DNA is transcribed into RNA, which is then translated into proteins. But what I think is really important to note is that you can take different combinations of DNA and thus build different RNA molecules from that, right? Resulting in, thus, different proteins. So what we've found is that cancer cells are actually really good at having unique RNA molecules that only they produce and thus result in these unique proteins as well that come from these cancer cells. So you guys might be thinking, how powerful would it be if we created a system to help our immune system recognize these novel proteins produced by cancer cells, thus targeting them and killing them? So that's kind of a general overview of what my work is going into today. So let's move forward and get into some background. So my work over the summer was based on my mentor's past work. This is the title of his paper that he published that really summarizes the whole project. So that's titled DNMT and HDAC Inhibition Induces Immunogenic Neoantigens from Human Endogenous Retroviral Element-Derived Transcripts. All right, so I know that sounds a bit like a mouthful, but I promise there's a lot of great information in there. So let's kind of break it down and see what's important to know from this title. The first thing I want to do from that is highlight two key players. So we have DNA methyltransferase and histone deacetylase. So basically what I need you guys to know are these are two different processes that when you inhibit them, it actually causes the DNA to open up more. And as we just learned, that results in more mRNA production from them and thus more protein production. So what we're doing here is we're using our two drugs, decitabine, which is a DNA methyltransferase inhibitor, and SB939, which is our histone deacetylase inhibitor, to cause, again, the DNA to open up and thus more transcription and translation to happen. So those are the two key players there. And what we found is that when you introduce these drugs to human cancer cells, we actually see increase of transcription of certain regions of the genome called human endogenous retroviral elements, and specifically in the long terminal repeat 12C family. What was really special about these to know is that LTR12C activation results in the production of treatment-induced novel polyadenylated transcripts. And if we can think of a nice acronym for those, we can call them TINPATs. So these are those novel sequences of RNA that I was referencing earlier that result in the production of those novel proteins. So our TINPATs to the novel proteins to then, which can be digested, so just broken down into smaller protein units that we'll call peptides. And these peptides can be presented on the cancer cell surface. And here's the exciting part, which leads to immunogenic neoantigen presentation. And what that basically means is immunogenic means that it can be recognized by your T cells. So in this case, we're talking about CD8 plus T cells. And then neoantigen just refers to the fact that it's a protein being presented on the surface of a cancer cell. Specifically, we're using MHC class 1 machinery to do this. So this is just a special class of protein receptors that cells use to present molecules on their surface. So that's some nice background for us there. And again, to bring it all home, we're using decitabine and SB939 are our two drugs resulting in the end result of neoantigen presentation. So I'll be giving a special focus to decitabine throughout the presentation just because that's the main drug being studied. All right, so I hope we're all feeling comfortable and excited. With that, we'll move on to the actual experiments themselves. So what was my goal over the summer? My goal was to create a mouse model acting as a preclinical model, demonstrating that upon decitabine treatment, we see this in-mouse phenomena of MHC1-mediated antigen presentation. Because all the data I just shared with you guys a few minutes ago, we saw this happen in human cancer cells. However, before we moved to, of course, in-mouse testing, and eventually, of course, the end goal of creating an mRNA vaccine for cancer patients, we first have to check, does this whole process indeed happen in mouse cancer cells, so that we can set ourselves up for future experiments. So that was the goal for my experiments there. And this is just outlining that we need to make sure that it works in mouse cells before we move on to actual mouse testing. All right, and here we have our treatment groups. So we'll break it down super simple. DMSO is our negative control, so don't need to worry about that too much, but important to have in our experiments. Decitabine is, again, our DNA methyltransferase inhibitor. SB939 is our histone deacetylase inhibitor. And then lastly, we had that combination treatment to investigate synergistic effects. So we're really going to be focusing on the decitabine and then also that combination treatment today. All right, and again, just as an overview, we're introducing decitabine to our mouse cancer cells, hoping we see induction of these special repeats in the genome, leading to the creation of those TINPATs, those RNA molecules, resulting in the production of those novel proteins presented on the cancer cell surface, making them recognizable to our T cells. Wonderful. And the first thing we wanted to do is validate the beginning of this pathway, because you guys can see there's a lot going on here. So we want to ask ourselves first, is this indeed happening? And if so, do we actually see induction of these long terminal repeats in our mouse cancer cells? And if so, do we also see production of these TINPATs? So that was a big question with that. And I just want to familiarize you guys with the two transcripts of interest that we'll be focusing on today. So as you can tell, our MMER-VK10D3, IAP, those are different than the ones that we're talking about in human cancer cells. That's just because in mice they have different repeats, so you can kind of think of these as the equivalent of our LTR12C repeats, except in mouse cancer cells. So these are the two repeats that we'll be focusing on. This data is from my mentor, Dr. Gralow. He did an experiment earlier on in mouse cancer cells. Basically, he was looking for the right repeats for us to investigate once we got to my experiment. So that's what this graph is from, and the big takeaway here is that's going to be the two repeats that we're focusing on today that we're hoping we see overexpression of. So moving forward, again, TINPATs leading to novel proteins to peptides, so won't forget it. All right, so here's the data from that first repeat and analyzing. So this is the culmination of my work from the summer. So I was treating the cells with decitabine. We isolated their RNA, and then we got to see, did we indeed see overexpression of these specific repeats in our mouse cancer cells? So this was really exciting because this shows, yes, for this one we did. So as you can see, with our decitabine and SB939 treatment, we indeed saw an increase in mRNA expression. So this is saying, fantastic, we're seeing production of these novel TINPATs. Same thing with our MMER-VK10D3 repeat. Again, our decitabine treatment and the combination treatment is resulting in a significant induction of these repeats in cancer cells. So this is really exciting for us because, like I said earlier, now, great, we've validated that first half of our pathway there. And then the question really became, can we validate the second half? So that's what we're going to get into now. RNA sequencing and immunopeptidomics, I'll break this down for you guys, but these are basically two tools that we used to check that second half of the pathway, because again, we've seen that this happens, but now are we indeed seeing these antigens being presented on those mouse cancer cells? And if so, you'll see we're gonna get to map exactly where they came from in the genome. So let's do it. First, RNA sequencing, we used Illumina and Nanopore. Illumina, there are just two different ways to sequence RNA. Illumina is short read, Nanopore is long read. What I want you guys to know from this is that basically you can think of this as our DNA, and we're just looking for mRNA expression from certain regions of the DNA. So this allows us to map the mRNA we're seeing. Where in our DNA is it coming from? All right, and then immunopeptidomics is a really powerful tool to pair with this. We're going to get to isolate those proteins being presented on the cancer cell surface and analyze them. So we are able to bring everything together. So this is the results from the immunopeptidomics experiments. This is from Dr. Jonas Becker at the German Cancer Research Center. So his team is one of our wonderful collaborators, so they ran these results for us. But it's important to take away here is that all these black dots, all of these are treatment-induced neopeptides. So those are those immunogenic neoantigens I mentioned earlier. This was really exciting because we were able to see that, yes, indeed, these mouse cancer cells are presenting those neoantigens on the cell surface. And what happens is when you pair this data with our RNA analyses that we performed earlier, we're not only able to see exactly where in the genome we have mRNA expression, but we're also able to map that expression to the new antigens being expressed on the cancer cell surface. So to finish us out in summary, I think this picture really brings everything together and shows you guys the flow and just how exciting this is that we were able to see these results. So I want you to look at these repeats up here. Let's see if I can hit it right. Oh, yeah, there we go. So this is, you can kind of think of this as the DNA. So we're looking at specific segments of the DNA. You'll notice that specifically we're looking at IAP, which is one of those key repeats that we were hoping to see mRNA induction from. And then you go down, if we look at our treatments, so decitabine, this is a negative control, so we shouldn't see any expression there. But from decitabine, we're able to get that mRNA reading, so we can see that we did indeed have expression, again, at the mRNA level with the introduction of our drug. And the most exciting thing, though, is to track down. We can see the antigens that our model predicted would result from this mRNA expression. And then right here at the very bottom, this is one of those treatment-induced neopeptides that we're actually able to find in the mouse cancer cells, and thus validate the second half of the experiment and say, wonderful, not only do we know now that we have novel TINPATs being produced from decitabine, but also those TINPATs are resulting in proteins being digested into peptides and presented on the cancer cell surface, thus creating that system by which T cells can then find the cancer cell and destroy them. So this was a really wonderful and I think conclusion to my experiment. We're still not analyzing the results, so those are ongoing. But what I think is a positive takeaway there is that now we're ready to move on to our in-mouse experiments, which we're very excited to do. So in the interest of time, that's all I can cover today, but I would love to say if anyone wants to connect afterwards, I'm more than happy to give you guys a little bit more insight into my work there. But yeah, with that, I just want to offer too a thank you, of course, to the German Cancer Research Center. I learned so much from my mentor, Dr. Goyal there. Also the Division of Cancer Epigenomics was just so kind to host me and take care of me all summer. And of course, the biggest thank you to Pepperdine. I couldn't have stayed there without them, so just the way that they made that happen for me was so wonderful. I'm always appreciative for that. And then lastly, of course, to my family and friends throughout this whole process. So thank you very much. Perfect. Thank you. Wonderful. And with that, I'd love to invite Chair Smith back to the stage to help close us out.
Okay, so guess what? It's Madison's birthday today. Madison, we're really proud of you. Really, really proud of you. Thank you for all the innovation, for your creativity, mostly for your tenacity. This woman is tenacious. She brought this to life. It was your vision, and we're so proud of you. Happy birthday. Okay, my next order of business is to promote yet again the Future of Healthcare Conference with a particular AI focus in healthcare. That is on March 12th. I really hope that you'll register for that. This is a thing at Pepperdine, right? We are investing in healthcare and we are investing in your access to just incredible information. I am going to wrap up now by introducing our beloved President Jim Gash, who has made this possible, who is the most incredible partner, whose vision for Pepperdine and for healthcare access at Pepperdine is really unmatched. He is a friend, he is a brother, and I love and respect him deeply. President Gash, will you come and close us out?
Thank you, Deanna. What an inspiring day. I was going to explain most of the stuff that Madison was going to explain, but she beat me to it. So I'll just let it stay there. I got 3 simple words in conclusion. Wow, and thank you. Today has been a powerful reminder of what can happen when rigorous science, generous collaboration, and a deep concern for human flourishing come together. We have spent the day talking about innovation, discovery, and treatment, but always with an eye toward the people whose lives are touched by this work: patients, families, and communities. Let me return the expression of gratitude to the beloved chair of the Pepperdine Board of Regents and the entire Board of Regents. Deanna, your vision, your leadership, your tireless commitment to Pepperdine, you bring this institution strategic wisdom and steady guidance. You bring a deep understanding of healthcare, innovation, and a deep care for the common good. Your work here at Pepperdine and across the broader healthcare community embodies the integration of excellence, compassion, and purpose that's the very heart of Pepperdine. I can tell you, as the president of Pepperdine, we would not have our new College of Health Science without the leadership and strategy of Deanna Smith. So thank you for your role in this event and for your leadership for Pepperdine. Let me also extend my sincere gratitude to Dr. Julie Gralow for your leadership, for your scholarship, and for your generous presence with us today. Your work with the American Society of Clinical Oncology and your commitment to improving cancer globally set the tone for this symposium and are an inspiring example for our students. Thank you, Dr. Gralow. And while she had to go, I want to stop and also thank Terry Palastro for sharing her story with such courage and clarity today. Her testimony reminds us that our work matters. Research, policy, and innovation ultimately find their purpose, not in abstracts or data sets, but in real lives. Lives marked by hope, resilience, and dignity. And to all of our panelists today, thank you for being here and bringing both your expertise and your humility to this conversation. You spoke candidly about the current realities of cancer treatment and the work that's still ahead. And you gave our students a clear and compelling picture of the field that they will soon be entering. I also want to express my deep appreciation for the faculty, clinicians, and researchers who joined us both from Pepperdine and outside for the good work that you are doing here, not just here at Pepperdine, but more broadly in our communities. And to our students, especially those who presented today, thank you. You are the heart of this symposium. Your curiosity, your care, your courage to ask hard questions are exactly what we seek to cultivate here at Pepperdine. Seeing undergraduates' research activity actively contributing to the life-changing research is one of the great joys of this day. So thank you to our students. And of course, a particular thanks to one of our students in particular, Madison Johnson, whose vision, leadership, and perseverance brought this symposium into being. This event exists because a student had a vision and then worked diligently to make it happen. Thank you, Madison. Let me also thank Divisional Dean Tim Lucas, the Natural Science Division, Seaver Dean Lee Katz, Provost Brewster, and all of the many faculty and events team staff who put the efforts into making this happen. Events like this they don't just appear, they have to be driven and led by excellent professionals. So we're grateful for your work today and always. As president of Pepperdine University, I'm often asked what distinguishes Pepperdine from other institutions. Days like today offer a clear example. One example that Deanna alluded to when she asked Lindsay a question about her relationship with her faculty here while she was a student reminds me of something that former law school dean Ron Phillips, who happens to be here in the audience, used to say to us when I was a professor at the law school. He was fond of saying that lawyers will interact with their clients the way that their professors interacted with them. The same thing is surely just as true, or perhaps more so, that healthcare professionals will interact with their patients in the way that their professors interacted with them. The close mentoring relationship that our students have with their professors will pay dividends, not just while they're students, but for their patients as they mirror that relationship down the line. We are a university committed to rigorous science. I hope that was clear to you today. That we pursue with intellectual honesty and an unwavering pursuit of excellence. We're a university committed to formation, to helping students discover not only what they can do, but who they were created to be. And we are a university committed to a greater purpose. The conviction that knowledge is ultimately meant to serve the world. In oncology, perhaps more than any other field, we see how inextricably knowledge is bound together with compassion. This work that demands technical mastery, perseverance, and collaboration. It demands humility, care, and hope. For us, as a Christian university, this is not abstract. We believe that all healing ultimately finds its source in our Creator God, and that one day He will wipe every tear from our eyes, and death shall be no more. And we believe that those who devote their lives to caring for the sick are ultimately continuing the healing work of the great physician. Our aspiration that this symposium will not be a one-time event, but part of a sustained culture here at Pepperdine, one that will continue to bring students, scientists, clinicians, and leaders together in the service of the common good. As we leave here today, I hope you will carry with you a renewed sense of purpose in your work, a deeper appreciation for the people alongside you, and a clear reminder of why your efforts matter. As the Apostle Paul reminds us, let us not become weary in doing good work, for at the proper time we will reap a great harvest if we do not give up. As we close today, you are invited to a reception just outside and to the right in the Weizmann Museum courtyard where refreshments will be served. And tours of the museum will be available to those who are interested. Shuttles will run until 3:50 p.m. Thank you for being part of this inaugural symposium. Thank you for the work that you do. God bless you all.